hope it's still morning. And
good morning, Madam Chair. Can I be heard?
Yes, you can.
Great.
Did you want to speak now? You're just making sure you're in.
There was a problem with the technology, so I'm glad I can be heard now.
Yes. I had a problem as well. I was becoming very frustrated, but finally it came through. So I'll call this meeting to order, and without objection, the chair is authorized to declare recess at any time pursuant to House Resolution 8. Today, the committee is meeting virtually, and I want to announce a couple of reminders to the members about the conduct of this remote hearing. First, members should keep their video feed on as long as they are present in the meeting. Members are responsible for their own microphones. And please also keep your microphones muted until you are speaking. And finally, if members have documents they wish to submit to the record, please email them to the committee clerk, whose email address was circulated prior to this hearing. And so, again, good morning and welcome to this Science, Space, and Technology Committee for the 117th Congress. We have an accomplished set of members on our committee. I just listened to one, and we bring diverse backgrounds and perspectives to our oversight and legislative work, and I look forward to a productive and stimulating 117th Congress. It is fitting that our first hearing focus on the COVID pandemic and the role of vaccination in fighting this virus and its devastating impacts. As the first nurse elected to Congress, I'm deeply committed to understanding how basic research supports healthcare solutions, and I'm also a firm believer in vaccines. Many of you are too young to know anyone who suffered from polio, but it was a devastating viral disease. I was a student nurse back during that time, and I helped to administer polio vaccine as a student nurse. And thanks to scientific breakthroughs by brilliant virologists in the 1950s, the tremendous vaccine administration campaign that followed, this country has been polio-free since 1979. And we didn't get there by accident. We took great care to educate the public, ensure vaccine access in marginalized communities, and to assist other nations in vaccinating their own populations. Like polio, COVID-19 kills. The last 12 months have been of great suffering, but they have also seen astounding achievements in the virology. Researchers at the National Institute for Allergy and Infectious Disease and their research partners laid the scientific foundation over the past decade for a new type of vaccine called mRNA. When the news of the viral outbreak in Wuhan reached the United States, NIAID quickly deployed partnerships with drug companies to develop safe, effective vaccines in record time. I cannot overstate what an incredible achievement it is that we have two safe, effective vaccines that have reached our shores. A third vaccine is being evaluated by FDA as we speak, and we may have an answer on whether it is authorized as soon as next week. We have an opportunity to take the lessons learned from polio, from measles, and so on, to make sure that these vaccines reach their potential. Here's one lesson. Vaccines don't save lives. Manufacturing billions of doses and distributing them are the supply part of the question. But in order to get needles into arms as quickly as possible, we also have to think about demand. There are a lot of factors that make up consumer demand for a vaccine, but perception of risk is a big one. We must build high public confidence in these vaccines. We simply cannot and will not bring this virus to an end unless we vaccinate a high percentage of the American population, and in fact, the globe. I hope our hearing today will help illuminate the methods that allow these vaccines to be developed and approved quickly with scientific rigor, and that we will learn more about how vaccine hesitancy might threaten the pace of our national recovery. The Science, Space, and Technology Committee may not have primary jurisdiction over health and human services, but we absolutely have a role in supporting public health outcomes through good science. I welcome our esteemed panel of witnesses and thank Dr. Huang in particular for joining us. As Dallas is facing unprecedented power outages, freezing temperatures this week, I know the demands on his time are intense right now because we are also with much of an uptake with the virus. So the chair will recognize Mr. Lucas. Did he get in?
Yes, Madam Chair. And thank you.
Thank you.
You and I both had challenges getting on board this morning, but we're both here. Good morning, Chairwoman Johnson.
Thank you.
Thank you for holding this important and timely hearing. And thank you to our expert witnesses for their participation today. I hope we can learn valuable information that we can share with our constituents as we continue to battle the COVID-19 pandemic. Almost 1 year ago to date, the Science Committee held our first hearing on the COVID-19 pandemic. Since then, we've seen day-to-day life changes dramatically. Millions of people have suffered from this pandemic, and COVID-19 has claimed the lives of nearly 480,000 Americans. In recent weeks, the United States reached a positive milestone as more Americans have now received at least one dose of the vaccine than have tested positive for the virus since the pandemic began just over a year ago. According to CDC data, the United States has administered approximately 55 million doses of COVID-19 vaccines since the first shot was given on December 14, 2020. And approximately 12% of the total U.S. population has received at least one dose. But as the original COVID-19 virus and new variants continue to spread across the globe, it is imperative that the U.S. take a more aggressive and ambitious approach to ramping up vaccine manufacturing and distribution. We need to get as many shots in arms as quickly as is possible. It's also critical that rural and underserved communities are not left behind during the vaccine rollout. For example, many rural residents lack broadband internet connection and are unable to secure appointments, which were largely scheduled online. Residents in more isolated parts of the country also experience difficulties finding somewhere to get the vaccine if they do not live near pharmacies or community health centers. Distributing vaccines that require ultra-cold storage also presents challenges for these communities, as doses will expire if they're not properly stored. The American research enterprise, including government, academia, and industry, has the expertise, resources, and talent to continue to fight this pandemic. From vaccine development at record speed to PPE manufacturing, America's scientific community has stepped up to the plate. As scientists and researchers immediately pivoted at the start of the pandemic to focus on combating COVID-19. With the integration of technologies such as artificial intelligence and high-performance computing, researchers have identified promising vaccine candidates quicker. Advanced manufacturing techniques also offer promising methods to bolster supplies and rapidly modify vaccines to address new strains of the disease. These factors allowed the U.S. to approve 2 safe and effective COVID-19 vaccines just 1 year after the pandemic began. Scientists were able to develop these vaccines in record time thanks to almost 2 decades of basic research on related viruses. These investments in basic research have truly been life-saving. We must continue to make critical investments in American research for the health and safety of our nation. As vaccine distribution ramps up, we continue to work to stop the spread of COVID-19. It is imperative that key decisions are grounded and backed by strong science and data. We simply cannot afford to ignore science during this critical time. This morning, I sent a letter to the chairwoman respectfully requesting a hearing regarding the science on safely reopening and maintaining the nation's K-12 schools for in-person learning. Research has established that approved COVID-19 vaccines are safe, and the evidence shows it's also safe to open our nation's schools with the appropriate precautions in place. I look forward to hearing from our witnesses today about the current state of vaccine uptake, hesitancy, and access across the country. I'm also looking forward to hearing from Oklahoma's plan and learning more about the efforts taking place across the state to ensure that the underserved and rural communities are not forgotten. Thank you, Deputy Commissioner Reed, for your participation here today. And I want to thank the witnesses for taking the time to be here to share your expertise and insights with us during this pivotal time to keep Americans healthy. I know we're all looking forward to the day all Americans can safely return to work, our children are back in school, and we can look our loved ones in the eye once again. I yield back the balance of my time, Madam Chair.
Thank you very much. At this time, we'd like to introduce our witnesses. Our first witness is Dr. Kathleen Newsel. Dr. Newsel is professor of vaccinology medicine and pediatrics, as well as director of the Center for Vaccine Development and Global Health at the University of Maryland. She was part of the leadership team which oversaw the evaluation strategy for COVID-19 clinical trials. And she's been a central figure throughout the COVID-19 vaccine development process. She has led phase 1 trials of Pfizer vaccine and the co-author of a recent paper establishing the efficacy and safety of the Moderna vaccine. And then after Dr. Newsel, Dr. Philip Huang. Dr. Huang is the Director and Health Authority for the Dallas County Health and Human Services Department, where he manages almost 500 public health professionals. Prior to that, he spent 11 years as Medical Director and Health Authority for the Austin Public Health Department. He also serves as an Epidemic Intelligence Service Officer with the CDC, where he conducted infectious disease outbreak investigations. Our third witness, Mr. Keith Reed, is the Deputy Commissioner for Community Health Services with the Oklahoma State Department of Health. His public health career with the department has spanned 19 years and multiple positions. Mr. Reed also is a colonel in the Oklahoma Air National Guard and served multiple tours in support of Operation Iraqi Freedom and Enduring Freedom. He is currently assigned as commander of the 137th Special Operations Medical Group at Will Rogers Air National Guard Base in Oklahoma City. Our final witness is Dr. Allison Buttenheim. He is the scientific director of the Center for Health Incentives and Behavioral Economics at the University of Pennsylvania. Her research has focused on vaccine exemption policy and zoonotic disease prevention. Dr. Buttenheim is a member of the National Academy's Committee on the Equitable Allocation of the Novel Coronavirus Vaccine and a lead author of the new National Academy's report on strategies for building confidence in COVID-19 vaccines. Our witnesses should know that you will have 5 minutes for your spoken testimony. Your written testimony will be included in a record of the hearing. And when all of you have completed your spoken testimony, we will begin with questions. Each member will have 5 minutes to question the panel. We will open our witnesses' testimony now, starting with Dr. Newsel.
Chairwoman Johnson, Ranking Member Lucas, and distinguished members of the committee. I appreciate the opportunity to elaborate on my written statement to you and to elucidate how investments in science and technology, effective partnership, and resource allocation enabled the vaccine achievements of the past year. The consequences of the COVID-19 pandemic on our health, our economy, and our social well-being have been staggering. While the urgent need for a vaccine was clear, vaccine development is a lengthy, risky, and expensive process. Researchers first evaluate experimental vaccines in the laboratory and in animals. If a vaccine is safe and appears promising, it may go on to be carefully tested in people, but only if there is funding to do so. Many vaccines never move beyond early testing simply because there is no perceived market value and no funding. As part of the team that designed and conducted the early studies of the vaccines, I witnessed firsthand how the pandemic urgency shortened the vaccine development timeframe. Investments in basic science and technology were the key. Decades of work on understanding coronaviruses and other respiratory viruses enabled scientists to identify the appropriate target for the vaccine and to have a genetic sequence ready within days. Investments in the mRNA technology for other vaccines, influenza, Zika, and Ebola, and prior partnerships with vaccine manufacturers meant we understood how to deliver the mRNA and at what doses. Likewise, government-funded researchers brought sophisticated animal models and innovative laboratory methods to the vaccine efforts. The investment by NIH and others in clinical trials, infrastructure, and networks allowed experienced clinical scientists like myself to help design, execute, and analyze the studies in partnership with government and industry. Given my involvement from the start, I can attest that safety was never compromised by the speed of this effort. All trial designs were reviewed by ethics boards and the FDA. Experts with no ties to the products served on boards to monitor vaccine safety. The first participants to receive the vaccine were healthy adults who would be the least likely to suffer ill effects. The trials began with low doses and worked up to higher doses. The volunteers were followed carefully in the hours, days, and weeks after receiving the vaccine. We learned that the vaccine caused more side effects at the highest dose, but the immune response was not as good at the lowest dose. So a middle dose was chosen to move forward into trials. The first results of the mRNA vaccines were remarkable, showing more than 90% efficacy against disease and, importantly, against severe COVID-19. As most vaccine adverse events occur shortly after vaccination, the FDA required a median of 2 months of follow-up before emergency use authorization would be granted. Safety assessment does not stop at approval, however. The trials will continue for at least 2 years. As with all vaccines in the U.S., the CDC, the FDA, and the manufacturers will continue to follow vaccine safety. Through these systems, we are learning more, for example, about the rare allergic reactions occurring after administration of the mRNA vaccines. In summary, U.S. government investments in science and technology enabled the COVID-19 vaccine development achievements. We don't know what pathogen will cause the next pandemic. Coronaviruses and influenza viruses have proven their pandemic potential. We must likewise be prepared for outbreaks from less studied diseases due to arenaviruses, filoviruses, and togaviruses, for example. Our vaccine development can be better and faster, but only with continued investments in technology. We have critical vaccine supply shortages and people are dying. Finally, this outbreak has reminded us again that little-known viruses causing disease in distant parts of the world are relevant. Variants are emerging in the absence of vaccines. The U.S. must work in partnership with the World Health Organization and other international agencies to ensure an integrated global response and to ensure that COVID vaccines are available to everyone in the U.S. and around the world. Thank you.
Thank you very much. Dr. Huang. Unmute.
Okay.
One more click. That's it.
Is it click?
Yeah, you got. Click one more time. It keeps going off.
Can you hear
That's
me?
it. Yes.
Okay. Okay. Well, good morning, and thank you, Chairwoman Johnson, Congressman Lucas, and members of the committee, and greetings from frozen Dallas, Texas.
You're off again. Okay. It keeps clicking off.
Sir, you seem to be hitting the mouse twice or hitting a button twice, and that's just unmuting you and then muting you again.
Showing it me unmuted. Do you hear me?
Yes.
Yeah.
Okay. Muted. Okay.
You're on. Okay.
I'm not.
We hear you now, but you just went off again.
Okay, I am not touching anything. Huh.
Keep going. It went off again. I don't know what it is.
Can you hear me?
Yeah.
Oh, there, that looks good. Okay. Well, apologize for technical difficulties. Again, my name is Dr. Phil Huang, and as you heard, I'm the Director and Health Authority for the Dallas County Health and Human Services Department, where we serve over 2.6 million residents in Dallas County. I'm also a board member for the National Association of County and City Health Officials, NACHO, which represents our nation's nearly 3,000 local health departments. And I'm honored to be with you here today. Over my career, I've worked at the federal, state, and local governmental public health levels, and I've truly come to appreciate that not just politics, but all things really happen locally. Local health departments know our communities block by block, including the assets and barriers to care, the industries and living situations that pose particular challenges, as well as the community-level partners that have to be included in order to be successful. Even before a single case of the virus was detected on American soil, we at local health departments began to mobilize and engage our community and healthcare partners, as well as with our state and the federal government. This continues as we provide testing and contact tracing, and while standing up the largest mass vaccination campaign in our nation's history. To be successful, we have to have strong, predictable supply of vaccines, but supply, while absolutely necessary, is not enough. We must do more to build demand and facilitate equitable uptake of these vaccines. To do this, we must provide clear communication through trusted messengers and healthcare providers, allow for the opportunity for questions to be asked and an individual's concerns to be thoughtfully considered, as well as target outreach via the many unique formal and informal communication channels where people get their information. This takes a robust workforce, strong relationships, and time and resources so that individuals can get their questions answered and then access the vaccine within their community. The challenge of vaccine hesitancy is not new to COVID-19, but with nearly 500,000 Americans who've lost their lives to this virus and more challenging variants emerging, it highlights the importance of a successful and efficient mass vaccination effort. Addressing this is not a one-time event also. Instead, it requires engaging with hesitant populations on an ongoing basis to honestly address concerns, provide the information they need, and build the trust that is crucial to their confidence in COVID-19 vaccines and the systems that provide them. In Dallas, we've seen vaccine hesitancy among communities of color, especially the African American and Latino communities. The roots of vaccine hesitance, though, are varied. The mistrust from the African American community seems to be deep-rooted history, including the horrific Tuskegee studies of untreated syphilis in rural Black men, while concerns in the Latino community might stem from mistrust of government and skepticism of the vaccine development process. Among the Hispanic community, we're also hearing questions around whether an undocumented person can receive the vaccine, as well as concerns about providing personal information to the government needed to receive the vaccine. These challenges persist in healthcare workers as well. We saw that in some long-term care facilities, even though there was a federal program with the pharmacies that guaranteed that delivery, the uptake of the vaccine from the staff could be very low, with some facilities only having 42% of their healthcare staff taking the vaccine. Local health departments as chief health strategists within their communities are actively working on these actions to support equitable COVID-19 vaccine administration and uptake across all communities, all races, ethnicities, and other demographics and geographies. Currently in Dallas County, we have over 650,000 people who signed up on our vaccine registration list. However, our health department is only receiving 9,000 doses of vaccine per week. Vaccine hesitancy combined with a digital and resource divide has also meant that our registration list is skewed to the northern, more affluent areas of Dallas County. However, because we focused on the data, we've been able to tailor our approach with an eye towards equity. We provided vaccine distribution based on our vulnerability index to ensure we equitably distribute the vaccine as opposed to a first come, first served approach. We've also set up a professional phone bank so individuals without internet access or a smartphone can call to register, and we partnered with community leaders to host in-person registration events. We're also launching a paid media campaign to address vaccine hesitancy and get information out to the community about the registration process. We've seen firsthand how leveraging people that are respected by the community can increase vaccine confidence. And at one of our community registration events, heard a 65-year-old African-American woman lean over to her friend and say she decided to come because she saw the actor Tyler Perry on TV that morning say how important it was to get the vaccine. While today's hearing specific to vaccine hesitancy around COVID-19, I can't understate that this is an issue that was a challenge for us long before the pandemic, and our efforts to build confidence in vaccines are long-term and continuous, but every day we work on it to bring us one step closer to getting our population fully vaccinated. Thank you again for inviting me to testify today, and I look forward to your questions.
Real quick, excuse me for a moment, Ms. Johnson, real quick technical tip. If you press and hold the space bar on the computer, that only temporarily unmutes you, and when you release the space bar, it mutes you back.
Thank you very much. Now we'll have Mr. Reed.
Madam Chair Johnson and Ranking Member Mr. Lucas, thank you for the opportunity to speak today. My name is Keith Reed, and I'm Deputy Commissioner of Health for the state of Oklahoma. I'm here today to discuss our state's efforts to efficiently distribute and administer the COVID-19 vaccine and how we have addressed issues with uptake, hesitancy, and equitable access, particularly for those in our rural and underserved communities. To begin, we've been conducting surveys throughout the state to gauge vaccine hesitancy. As of our latest survey in January, we've determined that while most people are willing to receive the vaccine at some point, roughly 33% of Oklahomans do not plan to do so. Major reasons for hesitancy are lack of information on the vaccine and its development process and concerns about potential side effects. In this initial stage of vaccine distribution, where demand is greater than supply, we found success in hedging the initial uptake issues by taking an overlapping approach. In order to vaccinate as many Oklahomans as possible, we've opened eligibility to new priority groups before entirely vaccinating earlier groups. With this tactic, we hope to lengthen the window of opportunity for those that might be undecided about vaccination, providing an extended time frame to build consumer confidence in our program. To overcome hesitancy and access boundaries and encourage high vaccine uptake, a few key conditions are needed. One, vaccine supply needs to increase. As we all are well aware, with increases in supply, we can provide more options for appointments, protect more of our vulnerable populations, and increase vaccine eligibility to more Oklahomans. Two, vaccine access needs to increase. We are working to open up new access points to the vaccine. We currently have approximately 1,500 pandemic providers signed up to participate in vaccine distribution around the state, but can only engage a limited number due to supply issues. Getting vaccine to these providers, which include local pharmacies and many primary care providers, enables us to engage the most trusted sources in rural Oklahoma, giving us our best chance for high vaccine uptake. And three, communication about vaccine safety and availability needs to be clear and it needs to be consistent. We've been using a diverse network of communication partners to make sure that communication with Oklahomans about the vaccine is consistent, transparent, and accessible to everyone. We hold virtual media events twice weekly to provide updates to the public and partner with our local health departments to keep lines of communications open so Oklahomans are informed on a daily basis. We work closely with regional health directors, county health departments, and other local partners to reach communities across the state. These partnerships are critical in determining the best communications approach for their local constituents as they understand what will resonate in their respective areas. We use social media and our website to provide timely, regular updates on the vaccine. Information is shared online and with partners across the state. Above all, we're ensuring that our communications across the board are clear and factual. Our top priority is to give Oklahomans the tool to make an informed decision about the COVID-19 vaccine. This requires regular, repeated, and reliable communication that is honest and direct in its approach. Oklahoma's unique landscape poses a particular set of challenges. Many of our community members lack internet access, particularly in rural areas with limited reception, or they lack digital literacy, particularly in our 65-plus community, who are some of the most at risk for COVID-19. People in underserved or rural communities have expressed higher rates of distrust in vaccines in general. Many people of color are wary of vaccines due to a history of medical mistreatment. There is a fear of being targeted due to immigration status or disclosure of race or ethnicity. There is also, of course, general misinformation about COVID-19, leading to skepticism of the actual risk posed by COVID-19, or even skepticism that the virus exists at all. This misinformation is perpetuated on social media, where it can have an exaggerated local influence. Our goal with vaccine rollout is to address these concerns in a clear and compassionate way. We found our partnerships with local entities have been invaluable in contributing to a much smoother rollout process and ensuring everyone's health and safety when they receive the vaccine. In Oklahoma, our surveys and experiences on the ground have shown us that two things are sorely needed: clear, accurate information about vaccine safety and efficacy, and increased vaccine accessibility to ensure equity. Thank you again to Chair Johnson and Ranking Member Representative Lucas for the opportunity to provide this testimony during such a critical moment in our nation's history. I hope you find this testimony helpful in your endeavors, and I'll be happy to address any further questions regarding Oklahoma's experience with the rollout of COVID-19 vaccine.
Thank you very much, Mr. Reed. We will now hear from Dr. Buttenheim.
Thank you, and good afternoon, Madam Chair, Ranking Member Lucas, and members of the committee. I'm Allison Buttenheim. I'm an Associate Professor of Nursing and Health Policy at the University of Pennsylvania School of Nursing, and I'm a behavioral scientist who studies vaccine acceptance and vaccine hesitancy. As Chairwoman Johnson mentioned, I had the honor of serving last year on the National Academies Committee on the equitable allocation of the COVID-19 vaccine. And as part of that effort, recently co-authored another National Academies report entitled Strategies for Building Confidence in the COVID-19 Vaccines, on which my written testimony was based. That report is chock full of very specific communication and engagement strategies to address hesitancy and ensure demand for our truly amazing COVID vaccines. And we hope it'll be a helpful guide to public health agencies at all levels working on vaccine rollout. In my very brief time with you today, I'd like to expand on that report and share some additional insights and evidence that can further guide us as we tackle the last mile challenge of getting shots in arms. Here are 5 science-based solutions that I hope Congress can endorse, fund, and promote. Number 1, embrace the dual goal of vaccinating efficiently and equitably. This recently has been framed as sort of a false choice or an either or, with people saying that we can either be fast or be fair with vaccine rollout. We have the science to do both, but we have to be deliberate, intentional, and innovative in our approach to both tracking and achieving those complementary goals. Number 2, fix the easy stuff. Hesitancy is definitely a barrier to vaccination, and I look forward to talking about that, but so are hassle factors. Even people who are motivated and excited about the vaccine can be deterred by the smallest amount of friction in the system, whether that's complex logistics, inconvenience, or confusing instructions. Making and keeping a vaccination appointment should be easy and hassle-free, and frankly, fixing those hassle factors is often easier than changing someone's mind. Number 3, keep doing the hard stuff, even if it doesn't scale. There are a lot of people with very legitimate concerns about the speed of vaccine development, diversity of trial participants, or trust in the medical research establishment. What's emerging as the most effective way to help those folks is sustained, repeated one-on-one conversations with trusted peers or vaccine validators. Now, you can't bake that kind of engagement into a chatbot or a website FAQ or a message on the side of a bus or even a TikTok video. We have to stand up and support those time-intensive interventions and get them to the people who need them, even if they don't scale. Number 4, use fun and delight. As Cass Sunstein has said, there's a deep human need to smile and laugh, and we can leverage that need through evidence-based messaging and promotions that exceeds people's expectations about the vaccine and about getting vaccinated in surprising ways. One example that I hope you've all seen is the Sleeves Up NOLA public service announcement from New Orleans. If you haven't seen it yet, watch it right after the hearing today. It's on YouTube. I'll send you a link. It's a truly fantastic example of that idea of leveraging fun and delight. Lastly, number 5, fail fast, learn fast. Behavioral science advances in much the same way that lab science does. We generate hypotheses about an effective intervention, and then we test those hypotheses via experiments. We need to bring the same speed and rigor to vaccine acceptance research that we brought to vaccine development research, so we can get it right in real time and also learn for next time, because this is not our last rodeo. Both immediate and long-term investments in behavioral science research are needed. So to recap, we can be fast and fair. We should address hassle barriers to vaccination in addition to hesitancy barriers. Some of our most effective strategies won't scale, and that's okay. Fun is effective, and learning what works is critical. I want to thank the committee for your time today and for your commitment to a science-driven vaccine rollout.
Thank you so very much. That completes the formal testimony of our witnesses, and now we will start our question and answer period. The chair will recognize herself now for 5 minutes. And I'll start with Dr. Huang. Let me first thank you again for being here with us today, and I'm glad that your family is safe, and I hope you have power. I toured the vaccination hub at the K. Bailey Hutchinson Convention Center in Dallas a couple of weeks ago, and I really was pleased to see how smoothly the operations are going. I attended the other one, but it was after the vaccines had run out, so it was not operational that day at Fair Park. So I commend all of the health professionals who are working tirelessly to get people their shots and the volunteers who are assisting. You said in your testimony that reducing logistical barriers for patients is a big factor in encouraging vaccine uptake. Making it easy to register for a vaccine is one example. If you could advise the rest of the vaccine administrators in the U.S. about 2 or 3 specific strategies to deploy in making things easier, what would they be?
So thank you, Chairwoman Johnson. We have certainly evolved as this has progressed, and as mentioned by Alison Buttenheim, this learning and learning fast has been sort of our experience. And so, initially we had to get large numbers through registering people online, getting these things, but we really want to be equitable and, opening a professional phone bank so people don't need to have those technical capacity to do the registration. We're trying to do that. We're going out in the community with many of our community and political leaders to sign up people for that registration and to make the systems more easy for people to access this. We're moving from in-person walk-up sites to drive-throughs are some of the ways, especially for our older population with mobility challenges and with the cold and the weather. Again, it's trying to get that stood up. We have a partnership with FEMA that's going to be starting next week for some drive-throughs. Those are some of the logistic and hassle factors that we're trying to address and make it more equitable and make it easier.
Well, thank you very much. Mr. Reed, would you say the same, or do you have some other pointers you'd like to point out?
Well, I certainly would agree with Dr. Huang's assessment there. I think it's important to have options. We experienced the challenges with a registration portal we quickly realized that you can't have a single point of failure. Not one option works for everybody. We've engaged our pandemic providers and encouraged them to use their own types of systems to help register or provide appointments for patients so that we don't depend on one single system. We've also had to use and encourage the use of manual type of systems. We use our 211 system for those that do not have good technology options, that they can call and provide name, address, and phone number, and we push that out to local health jurisdictions so that they can proactively reach out to them to get them registered for vaccine. I think the biggest key is that we provide options. I think we need many options for the public because not one single thing works for everybody out there.
Thank you very much. Dr. Buttenheim, in your testimony, you acknowledge that there are high levels of particular distressing levels with people of color, almost 3 times more likely to die. And as Dr. Huang and Mr. Reed have observed that all of this firsthand in both Dallas and Oklahoma, and you pointed out that the mistrust is real. And I enjoyed your testimony. I thought it was very good and right to the point. But healthcare discrimination did not begin and end with the Tuskegee study. So we really need more just a PR campaign to overcome this distrust, because it is deep and painful for many people. Can you help us a little as to why it's important to acknowledge some of the past, but we got to move on and see what we can do for the future, because we still have minorities dying at a higher rate?
I think it's important to address those disparities for 3 reasons. One, they're the reality. So if we ignore that there are disparities and structural racism in health and healthcare now, we're not dealing with correct data or accurate data. It's also the root of some of the vaccine hesitancy that we're seeing. So if we want to close the gap on coverage, we have to acknowledge that. And I think being frank and honest about those conversations will also point us to the best kinds of interventions to make sure we're meeting people where they are, making vaccination services accessible and respectful, and hopefully that will convince people that vaccinating is the right thing to do.
Thank you very much. Any further comment?
None for
Thank
me.
you very much. Excuse me, go right ahead.
None for me.
This is Phil Huang. I mean, I'd really say that on the ground level, building that trust, but as was mentioned, acknowledging some of the issues that are out there, but trying to be as factual in providing that information and addressing what we're hearing. I mean, some of the types of things we're hearing, we hear from some, the distrust of government. People think we're putting something in the vaccine the government's putting something in the vaccine to track people. They're injecting influenza virus in this. A lot of different types of, misinformation that's out there. Again, that the government's trying to get more information for undocumented persons, things like that. And so we have to acknowledge these, but then, try to explain and truth and that trusted individual, community partner, healthcare worker, Tyler Perry, whoever. I mean, it was really, great to hear that story of how the impact that his statements on TV made.
Well, thank you very much. I've completed my questioning period, so I'll now recognize Mr. Lucas for 5 minutes.
Thank you, Chair. Mr. Reed, I represent a predominantly rural district, essentially the northwest half of the great state of Oklahoma. And you have experience in dealing with a unique set of challenges that poses through the COVID-19 pandemic. Could you expand for a moment on the steps that are being taken to ensure in particular that rural communities are not left behind as we combat this virus?
Yes, sir. So for us in Oklahoma, we have been very deliberate about ensuring that we are meeting the needs of rural Oklahoma. One of our initial goals was to make sure that during the first week of the vaccine rollout, we had citizens from all 77 counties that received some level of vaccination, and we were able to achieve that. We've done that by really leveraging our local public health systems. We use a hub and spoke method to allocate vaccine, to push it out to local health jurisdictions. We do a lot of centralized planning, but we're very big on a decentralized execution plan. So we ask those local health jurisdictions to work with their local partners who they've actually been planning for pandemic type of events for years. We've asked them to engage those partners, go into those communities, and provide access points for vaccination. And in doing so, we have seen points of dispensing sites set up in churches, in fairgrounds, community centers. In some cases, it's the health departments. But we have tried to leverage what is actually available in rural Oklahoma to meet these needs. From a centralized standpoint, we watch closely the percentage of the population in these rural areas that is being vaccinated so that we can continue to monitor our success and ensure that we have a program that is equitable and we don't have any part of the state that is being left behind. But overall, I would say the number one thing we're doing is engaging our local public health system and their partners in allowing them to make local decisions because they know what needs to be done on the ground to serve the citizens that they are responsible for.
Thank you, Mr. Reed. Dr. Newsel and Dr. Buttenheim. Mr. Reed referenced a recent survey in Oklahoma that 33% of my fellow Oklahomans do not plan to get the COVID-19 vaccine. And they cite lack of information on the vaccine, concern about development, safety, all those sort of things. In the remaining time I have, what can we tell our constituents back home to emphasize the safety of the vaccines authorized for use? Yes, you're writing my town meeting speech for me here.
I mean, I can say from a communication standpoint, luckily we have the amazing data that Dr. Newsel and her colleagues have generated from these trials. One thing that I think is important is that people need to hear it more than once, and they need to hear it from trusted communicators. That might be clergy, that might be local government leadership, that might be other family members who are doing the online research for them. But the main, the survey data that says the main concerns are the speed of the vaccine development. Dr. Newsel just walked through that in an amazing way. That, it wasn't tested on people who look like me. We actually had quite robust diversity in the trials, and we don't know the long-term side effects. We're starting to accumulate that data, and we have incredible safety profiles. So I think it's sort of hitting those three again and again and again, but making sure if people have another set of concerns that we hear those and address them as well.
Yeah, and from my perspective, at the end of every conversation, I want people walking away thinking disease bad, vaccine good. And it comes down to being that simple. And others who are professional in the area can come up with those communication messages. But sometimes we forget the disease bad part. This pandemic is killing people. It's killing minorities. It's killing people with poor access to health care. It's hurting our school children. It's hurting our economy. So we do have to remind people that there is a real reason that we're asking them to get vaccine. And then on the vaccine side, again, I have tried to emphasize the points that you heard, that safety is always paramount because we're giving vaccines predominantly to healthy people to prevent a disease. We did include high percentages of minority populations of different age groups. So everybody can point to the trial and say, somebody that looked like me received this vaccine. But I think the disease bad, vaccines good is something to always remember.
And as we, every 2 years, as elected officials will note, have to repeat it 17 times in a row to make an impression. Yield back the balance of my time, Madam Chair. Thank you for a wonderful hearing.
Thank you very much. I'll depend on the staff now to call on the other members.
Ms. Lofgren is next. Thank you so much. And thank you, Madam Chairwoman and Ranking Member, for this hearing. We have obviously a big challenge ahead of us in getting vaccine distributed in sufficient quantities that we are able to put this virus in the rearview mirror. And right now we have the hesitancy problem, but we also have a supply problem where, there are millions of people who are trying to get vaccinated, but they can't because there's not enough vaccine available. So I'm looking ahead, I guess, to a few weeks from now when there will be more vaccine. In Santa Clara County, for example, we have now managed to vaccinate more than half of the people who are 65 years or older, and we're moving into the next group, which is people with serious pre-existing health conditions, people who work in food, the grocery store workers, and other essential workers. I'm wondering whether the construct of signing up and then having people come in is really the wrong approach for this pandemic. I remember when polio vaccine was first devised, I was in elementary school and you had to have a permission slip from your parents, but the public health people came and they gave every kid in the school a vaccination. Why would we not go to every grocery store and offer the vaccine to every person there? Obviously, they have the right to decline, but I'm also mindful that peer pressure is a great educator. And if every other person around you is getting vaccinated, it may cause you to question, why wouldn't you? So who can answer that question?
Well, this is, I would say, as you've started out, the supply is the issue at this point. And as I think I mentioned, we have over 650,000 people who've signed up to register who want to be on our waiting list to get vaccine. And we're only getting, like the health department's getting 9,000 doses a week. So, the sign up at this point does allow us to distribute more equitably. So we are applying a vulnerability index, a proximity index to these and getting those appointments out. We started out with 75 years of older and then went down to 65 plus with the underlying health condition. So, but absolutely, when there is adequate supply, we want to make it with that availability that you're talking about. But the big limitation is we just don't have enough vaccine. So we're trying to get it and get it out equitably through some of these processes.
But there's no medical constraint or ethical constraint to just going to the grocery store and saying, now that we're in your tier, anyone who wants it can get it if we have supply.
Oh, if we have supply, absolutely. I mean, we want it to be like the flu vaccine, the annual flu vaccine, and you go to your drugstore or retail store or something like that.
Here's a question that you may or may not be able to answer, any of you, because it has to do with distribution of vaccine. But all of us, each state has rural areas where the capacity for the very cold freezing is not as available. Is there a way to direct the J&J vaccine to parts of the country where the freezing capacity is a real constraint to the program of vaccination, so that the J&J, which does not require that extreme measure, can be directed to the areas that might need it the most?
Yeah, so I think this will likely occur at the state level, and I'll let some of my colleagues comment. Here in the state of Maryland, even the differences between the Pfizer vaccine and storing in a minus 80-degree freezer versus storing in a minus 20-degree freezer have led to a distribution system at major medical centers versus outlying pharmacies and outlying clinics. So it can absolutely be done. It has to be orchestrated at the state and local level.
And not at the federal level, you're saying. I mean, for example, the District of Columbia doesn't have any rural areas.
I'm not sure I know enough about the federal distribution to comment.
Okay, fair enough. Madam Chairwoman, I see my time is just about expired. Thank you again for this hearing, and I yield back.
Thank you very much.
Mr. Posey is next.
Mr. Posey.
Thank you, Madam Chair, for holding this hearing on these important issues regarding the COVID-19 vaccination campaign. The vaccines are monumental achievement, the product of a massive government-wide effort to defeat this pandemic. Dr. Newsel, you were part of the development of the protocols for the 2 vaccines that we're using today, and I'm pleased to hear your testimony that Operation Warp Speed played an important role in getting these vaccines developed, tested, and in use in less than a year. You state that, quote, the closure of schools and lack of extracurricular activities is impacting the academic, social, and physical development of children with disproportionate impact on minorities. Persons of all ages are struggling with the effects of isolation, extreme lifestyle changes, and increased anxiety. Florida schools are open, yet it's surprising that while the CDC says it's safe for schools to open, we have states that are still locked down. Would you provide for the committee record studies documenting the harm to children resulting from school closures that you alluded to?
Yes, so thank you for your comments. And again, just to emphasize that the damages in terms of the pediatric population are disproportionate to minority communities. So as we're seeing in the adult population, the minority and disadvantaged communities are more likely to get COVID-19, and they're more likely to get severe disease from COVID-19. Similarly, the disadvantaged communities are less likely to have the tools, whether it's the computers, the ThinkPads, the mechanisms and the oversight for virtual learning. And so I can provide you references after the hearing, but they are falling more behind in their academics because of this disadvantage.
Thank you very much, Doctor. And each of the panelists can comment on this. I'd appreciate it. And it seems like there is so much to learn from our experience with this pandemic. We need to better understand everything from the origins of the viruses and the development of the therapies and vaccines to the pandemic preparedness and collaborations between federal, state, and local governments and public health officials. After 9/11, Congress appointed a commission to cut through the politics of finger pointing and focus on the facts. Last week, I introduced legislation to do the same thing for COVID. Do you think, each of you, that we could benefit from such a commission?
Thank you for the question. I think in science, as others have suggested, we have hypotheses, we test the hypotheses, and we look to move forward at every step. So I do believe that it's always helpful to evaluate what has happened, whether it's an experiment or whether it's a program, evaluate what went well, evaluate what we can do better in the future. So yes, I think I don't know exactly what type of program or commission you're describing. I think it would be useful for lessons learned.
Thank you.
This is Phil Huang. I mean, certainly with most incidents, we do after actions and hot washes and find out lessons learned and what went right and what went wrong. So that's always a best practice for any event, I believe.
Thank you.
Yes, this is Keith Reed. I would say that we have learned a great deal and put into practice a lot of things we learned for years of practice in emergency response based off of what you initially referenced occurred after 9/11 and such. Those partnerships we've created have made a big difference in our ability to respond right now. But there were things that did not go as planned. There were things that we put into motion that certainly was not the way we expected it to roll out. So looking back on that and evaluating what worked and what did not would be incredibly valuable. And I think it would help us moving ahead to ensure we are prepared for the next pandemic or other major emergency that comes down the pike.
Thank you.
And I would just add, hopefully we can also learn from some of the behavioral and policy interventions. How did we do at getting people to mask? how did different kinds of lockdowns and stay-at-home orders work, and use the 50 states and local jurisdictions as sort of case studies to see what was effective.
Well, I thank the witnesses and see my time has expired and yield back, Madam Chair.
Thank you very much.
Ms. Bonamici next.
Thank you so much. Thanks to Chair Johnson and all the witnesses. I also want to thank all the witnesses for the work that you've done to so quickly respond to the pandemic, and I applaud all the heroic efforts of the broader scientific and public health communities. There have been so many achievements made thus far in surveillance and testing strategies and therapeutics, and now multiple vaccines that are safe and effective. But as we know, we're still facing many challenges. We've spoken about some of those, distribution and the equity. I'm particularly concerned about some of the new problems that are emerging, for example, the viral variants. And evidence suggests that some of these variants may actually be more contagious than the original virus. The CDC reported that the highly contagious strain that emerged in the UK could become dominant in the US in the next few months. They've already reported cases in 42 states. And there are also the South African mutation, the variant initially detected in Brazil. We're seeing all of these happening. So we know that work is underway to determine how well our current vaccines protect against the variants and whether booster shots or other approaches may be necessary. So Dr. Newsel, can you tell us what you know so far about how effective the existing vaccines are against the new variants and what our options might be if we need to adapt how the vaccines are formulated or administered and distributed?
Sure. Thank you for the question. And you have absolutely articulated one of the biggest concerns right now with SARS-CoV-2, the emergence of these variants. The first point I would like to make is that these variants were emerging in a setting of no vaccination. And RNA vaccines make mistakes when they replicate. It's a feature of the virus. And so the more that they are replicating unmitigated and uncontrolled, the more variants and more mutations that we are going to see. So the variants are yet another argument to get vaccine out fast, and to have a global response, because variants that emerge anywhere are a threat everywhere. In regard to the vaccines, we're just beginning to learn about their effectiveness against variants. Fortunately, these mRNA vaccines, for example, are highly effective vaccines. They have strong, what we call neutralizing, which means you can stop the growth of the virus, antibody against the vaccine strain. It is diminished against some of these variant strains, but it's still effective. So when you're starting at 95%, you can lose a little effectiveness and still be an extremely good vaccine. Some of the variants emerging in other places, the variant first recognized in South Africa, for example, have some more dramatic effects, and yet we are still seeing this neutralizing ability. However,
thank you. I want to get to a couple more questions, but that's helpful. Thank you so much, Doctor. Dr. Buttenheim, Johnson & Johnson, as we know, has applied for their emergency use authorization for its vaccine, and that application will be considered soon by the FDA's Independent Science Advisory Board. So having more vaccines is clearly a good thing, but people may be understandably hesitant if offered an option that is found to be somewhat less effective than Moderna or Pfizer at preventing mild and severe infection. So the difference in these efficacy results received a great deal of media attention, but it's my understanding there have been 0 cases of hospitalization or death in clinical trials for all 3 of these vaccines, including Johnson & Johnson. So with the questions that are arising about the differences between the vaccines, how can we most effectively address the concerns with the public and really communicate complete and accurate information? And this is, I think, going to be an issue because it's my understanding that Johnson & Johnson is a 1 dose, although I know you probably likely saw this morning the news that perhaps Pfizer and Moderna could be effective as a 1 dose. But if we're using Johnson & Johnson, for example, in rural areas or with transient migrant populations, there's going to be equity issues there. Why are we giving those populations something that is less, or looks to be less effective? So could you discuss that, please?
Yeah, this is going to be a challenge. And I think as we think about the sort of choice architecture, how we arrange environments for people to make choices, one thing we don't want the average American doing is choosing their vaccine. This should be sort of your provider or this clinic is off or this state is using this vaccine in their program and lucky you get it. Those sort of extra choices that cause kind of cognitive load do not have a place here. And yet we have the sort of wonderful problem that we've all anchored on the incredible effectiveness of Pfizer and Moderna. So something from J&J that looks maybe a tiny little bit less effective, but is still a great vaccine is sort of seen as second best. So I think messaging, good risk communication and sort of evidence communication, but also strategic allocation of that vaccine to areas that can use the different vaccines appropriately will also be important.
Does anybody else want to weigh in on this issue? Any of our witnesses?
The folks who are actually doing vaccinating should weigh in.
Exactly. I'm going to ask Dr. Reed, you testified about vaccine availability in rural areas. I represent a district in Northwest Oregon that has urban, suburban, but also a lot of rural areas. So what are the sort of practical implications of Johnson & Johnson formulation? It doesn't have the same cold chain requirements as other vaccines. How meaningful would it be to have that option in rural communities specifically?
Well, it absolutely gives us more options when we're looking at rural communities. We've kind of worked out a hub and spoke model in order to handle the storage restrictions of the Pfizer vaccine, for example. The big advantage that we look at when we talk about Johnson & Johnson is some of these populations that, homeless populations, for example, when the likelihood of getting somebody back for a second dose is extremely difficult. Another area we're looking at where this would be a great advantage for us is potentially some high resource intense groups, homebound groups, things like that, to where trying to get enough resources mobilized to get 2 doses to these individuals may be very difficult. So Johnson & Johnson provides us an option for that. For us, it's about the logistical options of matching the requirement of 1 dose with a population that can really benefit from that and maximize their protection based off that.
Thank you. And I see my time has expired. I yield back. Thank you, Madam Chair.
May I make one comment answering?
Yes.
About the Johnson & Johnson? I just want to stress that the efficacy against severe disease for the Johnson & Johnson vaccine is very high. So while it's nice to prevent loss of taste and smell and cough, and what we really want to prevent are hospitalizations and death, and the Johnson & Johnson vaccine does that.
Thank you.
Thank you. Next witness.
Mr. Babbins, next.
Can you hear me? I'm sorry.
Yes, we can.
Okay. Yeah, thank you. Thank you, Madam Chair. Great to have your expert witnesses with us today. It's such an important Ms. Bonamici, information out now, and there was an article in the Wall Street Journal about
You might have to repeat your question.
Can you hear me, Madam Speaker? I mean,
yes,
Chair?
we can hear you now.
Okay,
we can hear you now.
Okay, thank you. I was just trying to find out what the latest is on the Pfizer in order to get more distribution of the to more individuals on the first injection of Pfizer. Is that something in the works right now? Dr. Noodle, are you?
Yeah.
Are you?
Yes, so I didn't hear you directing that to me. So thank you for that question. You know,
Sure.
The Moderna and Pfizer vaccines have very high efficacy after the first dose. If you take away that first week before your immune system has had a chance to respond to the vaccine, and when many people were likely already exposed to the virus and maybe even incubating the virus, you get to about a 90% efficacy after a single dose for both vaccines. The problem is we only know that for a very short period of time because 2 to 3 weeks later, we gave that second dose. Now, the efficacy isn't going to drop from 90% to 0 overnight. It will take time to wane. But in order to change from a 2-dose to 1-dose regimen, you would really need to follow those people who got a single dose for a longer period of time. We believe that second dose is important for duration of protection and perhaps protection against these variant strains. But if somebody's a little late getting their second dose, they should not be worried. It starts to work very well after 1 dose.
We can't hear you, Dr. Babin. Are we getting him some technical support?
Yes, Mr. Babbitt, you may be experiencing some bandwidth issues. If you'd like to just turn your camera off momentarily, that will allow the audio to clear up a little bit and stop using as much bandwidth.
Now, can you hear me?
Yes.
Okay. Following up on that question, that your answer there, Dr. Newsel, is there an antibody titer associated with this particular protection? And if it is the same antibody titer seen in a post-COVID infection, and if so, that leads to the question of whether we need to vaccinate those who were previously infected. Is there any change there? I know that's a question that's still ongoing, but what is your opinion there, and what is your knowledge concerning that?
Yeah, so that's a great question, and a very active area of research is to be able to define exactly the amount of antibody that is protective, because that will help us when we move to other populations, as you've said, when we vaccinate people who have already been infected. So it's a very active area of research. You know, ironically, having vaccines that are so protective makes that hard to establish because almost everybody in the vaccine group didn't get to the disease. However, we're pulling all of the information from all of the trials to try to understand that. Data indicate that if you have had the infection before, you likely do respond better to a single dose of vaccine. But we don't yet have enough information to translate that into policy right now.
I've got you. I don't know how much time I have left, but I was just wondering if there was an evidence for an anamnestic response, like antibody titer and T-cell activity, if they go below a certain point. Is there evidence that re-exposure to the virus might trigger a rapid immunological activation or escalation, which would give you protection as well?
Yeah, so another great question. And in fact, this was asked earlier. The companies now are very actively working on booster doses of vaccine with the same strain and with variant strains. So I would say within weeks, 2 months, we will have the answer to your question.
I am so glad to hear. We are in the middle of a bad winter storm down here in Texas, and it's been very difficult. I have a large rural district as well, and getting vaccines out there and getting people these questions that have already been asked. We have really a shortcoming when it comes to connectivity via getting information on the internet. So we certainly hope that some of you other panel members would be able to say how is this being addressed to get connectivity on the internet into these rural areas to get people this information. Can anybody answer that?
I would say in Oklahoma, we are trying to tap into every communication source we can for rural areas. Radio, through local organizations, connecting with churches. We're really trying to work through our community resources, our community partners to get messaging out. It's a challenge. It's a definite challenge when we're trying to vaccinate the entire population or make it available to the entire population. It's obvious the easy way is to default towards some kind of media that requires internet, but we have to fight that urge in some of these areas, and we've got to access these other resources to be able to reach them.
And I would have, in Dallas County, we are trying to do paid media. We're trying to do phone, making the phone a paid phone bank available, other community events in the community to sign people up and get them the direct connections.
All right, great. That's great answers. I want to say thank you very much. And Madam Chair, I don't see how my time is not coming up, so I may already be expired. Am I?
I can't tell.
Okay, I can't.
The staff people might be.
You're way over time.
The time is
way
expired.
over time. Okay, I'm sorry. I'm going to yield back then. Thank you so very much.
Well, thank you. Though, good questions.
Yes, ma'am.
Mr. Barra is next.
Great. Thanks, Madam Chairwoman. I'm going to follow up on some of the questioning that Ms. Bonamici asked. And I'm a physician by training, come out of academics, and have done clinical trials. And I'm extremely worried about how we're talking about the efficacy of the vaccines. And I even hear it in the discussion here today, because in truth, you have to design the clinical trial for a common event, which is catching the disease. But there are other outcomes that we're certainly trying to prevent with this vaccine: serious illness, hospitalization, and death. And we talk about the, Moderna and Pfizer as being more efficacious than Johnson & Johnson. That may be accurate in prevention of disease, catching COVID, but each of these vaccines are super effective in preventing serious illness, super effective in preventing hospitalization, and super effective at preventing death. And that, is the truth for AstraZeneca as well. That's the truth for Novavax on the data that we can see. And I'm extremely concerned that if we don't start with the positive message of it's remarkable that we have potentially 5 super effective vaccines that are going to prevent you from getting seriously ill, that absolutely are keeping people out of the hospital, and as far as I can tell, nobody's died who's received any of these vaccines. And I see our best spokespeople from the administration on television, on cable news all the time, and we fall into this message. And the risk that we're going to run is someone's going to say, well, I heard someone say Johnson & Johnson's not as effective, so I'm going to wait a while until I can get the Pfizer vaccine or the Moderna vaccine. And maybe, Dr. Buttenheim, this is kind of your area of expertise. I've seen you quoted in some articles, and I am extremely worried that we're setting ourselves up in a way that is going to slow down vaccinations. And again, those 3 other variables, serious illness, hospitalization, and death, all of these vaccines are incredibly effective. Would you give us, as members of Congress and others, again, because we fall into this trap. So what's the best way to message these vaccines?
I think there are a couple of strategies we can draw on. One is analogy, right? So no one asks what kind of vaccine they get when they go for their flu shot, right? It's not even an issue. You may not even know who makes your flu vaccine. And so we need to transition our vaccine promotion programs to be more like that. You're getting a COVID vaccine. I think we also need to, and this is unsettled science, but we need to think about how to, as you said, really hone in on the adverse events, the severe events that are not happening because of these vaccines. And this is always a challenge for health promotion, right? We're trying to get people to do stuff so that something else doesn't happen. That's really hard. And if the thing that's not happening is even more rare and probabilistic, that's additionally challenging. So I think we need to pull in our best, social marketing, advertising people to help with these frames and these messages that make most salient for people as they're making a decision, like any vaccine is a good vaccine decision here.
Right. And so starting with the positive, right? It's starting with that all of these vaccines are super effective at, preventing serious illness, keeping us out of the hospital, and certainly, preventing death. And if you can get a vaccine, get that vaccine, whichever one of those vaccines that are available.
The best vaccine is the one you can get tomorrow.
Exactly. And we probably have to start with that message.
Yeah.
Right? So, because, what I'm very worried about is in many rural communities and harder to reach communities, just logistically, the Johnson & Johnson vaccine may be the easiest vaccine to get out there. If you're vaccinating homeless folks, at a riverbank, a single dose vaccine is going to be a lot better. If you're vaccinating college students that may not come back for that second vaccine, a single dose vaccine is going to be better. I do worry, though, that there's that potential where folks might say, well, why are you using a less effective vaccine in some of these disadvantaged communities, and you're using and again, I don't think those aren't equivalent.
Right. And you're right to worry about that, because that is going to happen. So I think with J&J, we can promote, it's like the convenient vaccine, like one and done. On this one, isn't that great? But yeah, the more we can take that choice away from people and not fall into the I'm going to wait for Pfizer, the better off we'll be.
Right. So again, just to my colleagues, if we can start with the positive, that we are so lucky that, we have potentially 5 great vaccines that are going to do a remarkable job. Get that shot in your arm. So I think my time's up, and I will yield back.
Thank you very much. Great questions.
Mr. Gonzalez is next.
Thank you, Chairwoman Johnson and Ranking Member Lucas, for holding this hearing, and to our great witnesses for joining us. I think we're all in agreement the COVID-19 vaccine development is a marvel of modern medicine. To take a process that under most circumstances could take up to 10 years, have multiple successes in a matter of months is just incredible. We should all be incredibly grateful for the talented researchers and scientists. And I want to especially thank Dr. Newsall. I'd like to personally extend this thank you to you, because I know you worked so hard on this as well. At this stage in the pandemic, it's important that we satisfy our strategies into short run and long run categories. In the short run, I think we need to increase vaccine supply. That's been evident. Make efforts to rebuild trust and lay the groundwork for building demand so that when vaccines are readily available, there's sufficient uptake in the community. And then long run, we need to sustain outreach to vaccine hesitant communities and invest in research that improves our ability to identify people's perceptions of safety and tailor communication specifically to each population. Dr. Newsall, I want to start with you and a question. As these variants have come into play, what role do you think the federal government will need to continue to play from an investment standpoint? So obviously we front-loaded a lot of the investment on the initial development of vaccines, but as the variants take hold, will we need to continue providing that, or can the companies handle that themselves, in your opinion?
Yeah, thank you for that question. I think on the variants, it's going to have to be both. For one, we need a better surveillance system to pick up these variants, and we're really not there yet. And so that is going to be critical, and that is going to have to be coordinated, and that will need to be government funded. Again, we have to think about where are the incentives. And if there is not a natural market value and a market-driven reason for the companies to do it, that's when the public-private partnerships thrive, and the government needs to step in and help. This is why we never had an mRNA influenza vaccine, because who's going to take that to market when we have 10 other vaccines already on the market? And so that's the way we're going to have to think here and be strategic in the investments that are going to pay off for public health and won't naturally occur in a market-driven decision-making world.
Can I ask you a follow-up on the mRNA specific to the traditional flu? And you may have already answered this, but from your answer, should I assume that if we did an mRNA vaccine for the traditional flu, that it would be more effective and we could potentially cut down drastically on flu-related deaths as well?
So I don't think we can make that assumption. The mRNA vaccines for influenza have been in phase 1. They're immunogenic. Because of our ability to stabilize the virus, get the right sequence and get it faster, they may be better, but that has yet to be tested. They certainly have a speed advantage.
Thank you. And then the mRNA vaccine is easier to produce and manufacture, as you said. How easy will it be to alter the vaccines such as the J&J and AstraZeneca vaccines?
Yeah, so the J&J and AstraZeneca vaccines are also genetic-based vaccines. We're just using an adenovirus to deliver them instead of a lipid coat to deliver them. So they will also be amenable to rapid sequence changes.
Great. And then with my last minute, I can't see the clock, but just quickly, I know we've talked a lot about increasing confidence in minority communities, which is obviously critically important. We've started to see some success in Northeast Ohio in the Hispanic community with a program called Cover COVID, which is more of a national, international program. The short and long of it is it's not just about translating things into Spanish, right? For our community, what we found is it's the translation, but it's also having the cultural awareness to know that we have to do more than just translate to make sure that what we're translating hits the community in a way that they can receive it. And so that I just draw that to everybody's attention. I know everyone's working on this in different ways, but we have seen some success in the Cleveland area. And I just submit that to everyone for consideration. And thank you for your responses. I yield back.
If I could follow up for a moment on that, it's going to be so important to gather and collate those success stories and make them easily shareable across different populations. So again, we can learn fast what's working.
And I just add one thing, even the term Operation Warp Speed, we heard in the Hispanic community sort of gives this sense that it's been rushed through and that distrust of the government and things. So
thank you.
Is Mr. Sherman available?
Who's next?
Mr. McNerney is next.
Mr. McNerney. I see him. He's here. Mr. McNerney, unmute.
There we go. Well, thank you, Madam Chairwoman, for holding this hearing. It's a very interesting and informative. I recently hosted a town hall meeting on a range of issues regarding vaccination. Fortunately, I had the help of Dr. David Relman of Stanford, who was able to address some of these questions. But it's good to have experts that can give more information on this. Dr. Nuzzel, in your written testimony, you mentioned the collaboration necessary for vaccine development. That includes the Department of Health and Human Services and other relevant government agencies and partners abroad. Did the decision by the previous administration to withdraw from the World Health Organization put our country at a disadvantage in terms of the coronavirus in the last, did our isolation approach do more harm than good?
Yeah, so thank you for that question. I've been involved with the World Health Organization for the past 15 years or so and done work in countries around the world. Again, as I said in my testimony, it's quite clear that we have to consider any infectious disease, any new pathogen, anywhere to be consequential, and we must have a global response. In terms of, it's always difficult to go backwards and say what would have happened if. But certainly now we should be cooperating fully with the World Health Organization. We should be setting up these global surveillance networks, and the influenza surveillance network is a model. And we must work together and get vaccines to everyone in the world, or we all will remain at risk of SARS-CoV-2 infection.
Thank you. Well, in your testimony, you said that the emergence of 3 severe coronaviruses in the last 2 decades should encourage us to work toward a pan-coronavirus vaccine. Can you elaborate down a little more on what work is being done at this point?
Sure. I don't think a lot of work is being done yet. You know, we had the SARS virus, then we had the Middle Eastern Respiratory Syndrome virus, MERS, and now we have SARS-CoV-2. So in the same way we approach influenza as a class of viruses, in my view, we have to approach coronavirus as a class of viruses. For example, if we had antivirals the way we do for influenza, that can help bide some time. So medications, ideally oral medications that people can take during this time while vaccines are being developed. So I think we are going to need to approach coronaviruses in that way, rather than each one individually as it emerges. Think of them as a class, and what we can do either from the vaccine or the medication standpoint to develop countermeasures that would fight all coronaviruses.
Well, thank you. Dr. Buttenheim, I want to ask you about the same issue. I think it's safe to assume that we may see more variants in the coming months. What does the emergence of these variants tell us about the international approach to vaccinations?
Well, I mean, I think I'd go back to the, none of us is protected until we're all protected. I think it's a messaging challenge and a behavior change challenge for folks in the US, because of course we're trying to think, how can we get our population vaccinated as quickly as possible? We also need to motivate people for the US to be a player globally in providing vaccines to other countries in order to do things that we like to do as Americans. Like, we like to travel, we like to have people from other countries come travel here. And that will be impacted if the rest of the world can't vaccinate. I look every evening on some of the amazing trackers that show how we're doing as doses given per 100 people or per 100 million people compared to the rest of the world. And it's agonizing. I mean, we're doing great. We have a ways to go in the US, and much of the world hasn't seen a single dose yet. That's tough. That's tough to swallow.
Yeah, sure. Dr. Huang, you've discussed the difficulties faced in reaching and connecting with a variety of communities in our cities and states. How are you combating vaccine hesitancy and disinformation with the homeless population?
So we have definitely been working with the homeless population on testing, dealing with some of the outbreak situations. We have a lot of partners. I think what has been discussed in particular with them, the Johnson & Johnson vaccine being more amenable for that population. We have already been vaccinating those. In Texas, it's been the 1Bs are defined by either 65 years of age or older, or 16 to 64 with an underlying health condition. So we've been trying to do those populations within the homeless settings. And again, it's that communication and partnering with the other groups that we have that long-standing relationship with them. And right now, it's more of a vaccine availability issue.
Okay, well, I want to again thank the witnesses for sharing your expertise and your time, and I yield back.
Thank you very much.
Mr. Baird?
Yes, I want to thank Chairwoman Johnson and Ranking Member Lucas for putting on such a timely that we can share with our constituents. And I especially appreciated Madam Chair's mention of polio. One of the reasons I became involved in Rotary was because their efforts worldwide or internationally to help with polio. And so I think that really demonstrates the importance of the vaccination. And my question really deals with messenger RNA or mRNAs we've made reference to. That messenger RNA creates enough protein to stimulate our immune system, or whatever we're dealing with, the immune system, and that triggers the production of antibodies. And so I think that is a valuable asset in that we're not injecting modified live virus. But if you go back in the animal industry over the years, we used different techniques to vaccinate animals, one of those being a modified live virus. We altered it so that it did not cause the disease, or we weakened it in some way. And so I really think the selling point for getting over this hesitancy is the fact that we're not really injecting people with a live organism. It's only partially there, and it's a protein that stimulates our immune system. So, Dr. Nuzzo, you mentioned
I lost him a little bit. I don't know if other people did.
Yes.
Okay. So I didn't hear the question.
We'll see if we can get him to repeat it. He's talking, we just can't hear him. But he is unmuted. We can't hear him.
Yes, ma'am. I'm sending a message to Cisco now. I believe there's some bandwidth issues going on, and it looks to be across WebEx, not just with one individual.
Okay.
So I'm going to try one more time, and otherwise I'll say goodbye. Can you hear me now?
Yes.
We can.
Okay. My question is to Dr. Nuzzo. You mentioned animals, and I think that provides us a big database. But I really want to address the mRNA and the fact that I think it provides some protection for these variants. So I would like to give you a chance to elaborate on that a little more.
Sure. First of all, I agree with you, and it's a really important point that these mRNA vaccines are not weakened viruses. They absolutely cannot cause COVID-19 infection, and that's a very important message. They do allow our own cells to make the protein, which stimulates a very effective immune response, because our body does think, you know, it's the protein from the real virus. And that broad response we have shown from people who have been vaccinated with these mRNA vaccines can neutralize even these new variant viruses. So we don't know what difference that will make with disease, but at least in what we can measure in the blood, people who get these vaccines do have antibody that works against the new variants.
So, Madam Chair, well, thank you very much. I really appreciate that. And with that, I'm so close on time, and I need to excuse myself anyway, but I can't tell you how much I appreciate this meeting, and I think it's very timely. And so, thank you.
Thank you very much. Thank you. Our next witness.
Mr. Tonko.
Thank you, Madam Chair. Can you hear me?
Yes.
Oh, thank you for holding today's hearing on the critically important science and research behind COVID-19 vaccines. Obviously, vaccines are one of the greatest success stories in public health. With them, we have eradicated smallpox, nearly eliminated wild polio virus, and driven the number of people who experience the devastating effects of many other preventable infectious diseases to an all-time low. While I'm encouraged to see that so many people are getting vaccinated, including in my home district in New York's capital region, I know that many still have questions about the safety and effectiveness of COVID-19 vaccines, and this hesitancy might begin to affect the pace and equitability of our national recovery. So, Dr. Nuzzo, I do we have any scientific consensus on how many Americans will need to be immune to COVID-19 for us to achieve herd immunity?
Yes, so a very good question, a very popular question. You know, we have models that look at that. You probably know for a disease like measles, we look for about 95% immunity. We're hoping that somewhere, you know, upwards of 75 to 80% might get us there for this virus. Some of this will depend on these variants and transmissibility and duration of immunity.
Thank you. And Dr. Nuzzel, is herd immunity achieved through widespread vaccination the quickest way to return to a more, quote, normal way of life?
In my view, it is the quickest way to return to a normal way of life. And we have to remember with infectious diseases, we're talking a lot about relative efficacy numbers, but I am as protected by what the people around me do as what I do. So again, the more people that get vaccinated, the closer we are to returning to normal.
Thank you. And Doctor, what do you know right now about the effect of vaccination on transmissibility? What advice would you give to the public as that research continues?
Yes, it's a great question. And right now, the data that we have are in the early phases. However, the data are trending in a positive direction.
This morning that
We have data from AstraZeneca, we have data from Moderna, again, small numbers. The people who get these vaccines are less likely to have virus detected by a swab. So they have less virus in their nose. So the implication is if you have less virus in your nose, you will spread virus less well. We will know a lot more about this in the next 3 to 6 weeks or more. And again, we are very hopeful that these vaccines will also decrease transmission.
Thank you. Well, we're all anxious to return to our lives, but there are several key measures we need to hit before that can happen, obviously. In addition to vaccine availability, we also need to be moving as quickly as possible to produce good science-based research that we can share with the public and use to offer guidance in real time. So, Dr. Buttenheim, do you believe that state and local public health departments have the information they need right now to engage with their communities and increase vaccine uptake?
They have the information. They do not have sufficient resources. So we're here in Philadelphia. We're our own CDC vaccine jurisdiction, right? One of the 64 jurisdictions. We have a fantastic Department of Public Health. Huge shout out to PDPH. But there's a lot to do right now. You know, we need to set up vaccine providers in different kinds of clinics. We need to, you know, put messages on buses, as I said earlier, and we need to engage with, you know, community networks, community health workers to do all that outreach to folks who don't have, you know, aren't on the internet all day. That takes money. And if we're going to really rely on our local and state health departments to do vaccine rollout, which is appropriate, that's why we have jurisdictions, they need resources.
And how can Congress best assist state and local public health departments in their efforts to provide up-to-date information aimed at curbing COVID-19 vaccine hesitancy?
I think again, I'll go back to the money. In addition to those resources, what I mentioned earlier with making sure we have sort of clearinghouses and compilations of best practices and what's working in different areas. I think also we need really good dashboards, especially if we want to, you know, do the sort of double punch on the equity and the efficient rollout. Every jurisdiction should be able to pull up a dashboard that shows, you know, how we're doing, how many doses are out, how many doses are in jurisdiction, how are we doing on race, ethnicity, and age, and, you know, social vulnerability index. And those are intensive, you know, data resources. Support to get those stood up and keep them active and dynamic is also really crucial.
Dr. Buttenheim, thank you. I've exhausted my time. Madam Chair, thank you for your patience. I yield back.
Thank you.
Mr. Sessions is next.
might need to unmute.
Sir, you are unmuted, but no audio is coming through.
Try it again. Good. I hope that's better. We put a new microphone. Good. Thank you very much. I'll start back over. Thank you. Chairwoman Johnson, thank you very much for holding this hearing. Your leadership in this committee for years has been very important to many people, not just your background as a nurse, but representing a huge number of people by speaking about them. Also, Ranking Member Lucas. My question that I would like to direct, I believe it goes to Dr. Newsel, which would give her a heads up that I'm going to ask this question. The first is just a comment that may or may not require an answer, but the last two I am looking for one. And it is that for a number of years, I've been a blood donor, given 15 gallons of blood over my life. And I've watched it how these organizations come and work with local community-based organizations, including churches. And I wonder if it's appropriate ethically for us to consider going to churches and actually, you know, making sure you hit not just the Baptists and the Methodists and the Catholics, but other evangelical churches perhaps in an area. Perhaps it might be a synagogue, but working through the churches, which would bring people together where they are together on a Sunday morning or a Monday or Wednesday night. It seems that to me that may be a way that you could take care of what might be a disparity in the other communities that we're having problems with. Now to my questions. Number one, I'm a father of a Down syndrome young man and trying to stay up with issues related to disabilities. My question is that do you believe it's important for disabilities to have their own trial, or would you suggest that they be involved in these trials that go on? We have people, some who are in wheelchairs, some who cannot, maybe an intellectual or a physical disability. And secondly, evidently, we do not have our young students, I don't know the age, whether it's 25 or 35 and below, that really were not part of the adult study, but is a study necessary before we can get to all of our college students, or what is that status on the list? Thank you very much.
Yeah, so great questions. And it's very difficult because when we do a clinical trial, even trials as large as were done for these vaccines, 30,000 or more, you're trying to represent the population in which the vaccine will be used. But at the same time, you're trying to be safe. So as I said at the beginning, you want to start with people who are least likely to have the ill effects, and then move to older people, move to younger people. So we've moved very fast in adults, in older adults, in adults with chronic conditions. We haven't moved as fast in children. We're down to about age 12 with enrolling children in these trials. For the example you give, Down syndrome, many other developmental diseases, neurologic diseases, if the immune system is intact, we can extrapolate that these vaccines will work well in any of those populations as they have in these trials. It's really populations where the immune system might be compromised, where we don't have the data yet. These vaccines are likely to be safe, but we don't yet know how well they work, and companies and governments and academics are moving into those populations.
Good. Thank you very much. And once again, just a suggestion, you might want to move where we're having problems. I think that when you have the availability of the vaccine, that's the time to go in a area that either is rural, hard to get to, or where there is a reluctance and move to large groups of people. And that way your numbers grow. I think I heard you say, go away from failure and move to success. Make friends with success is what I agree with. And it's still, I mean, I'm not saying anybody is more important than anybody else in any of those communities, but I think that it gets the word out that when you go to a church, that they communicate with other people and say, I got mine, you ought to get yours. And that's, to me, success also. Thank you very much. Chairwoman Johnson, I yield back my time.
Thank you very much.
Mr. Foster is next.
Thank you. Am I audible and visible here?
Yes.
Yes, sir.
Great. All right. Well, thank you, Madam Chair, and to our witnesses. You know, one of the lessons that I take away from COVID-19 is that we have much to learn from the rest of the world. So, Dr. Nuzzel, in Britain, the EU, Singapore, and other countries, they're making 3 significant choices differently than in the U.S., and I'd really be interested in your reaction to them and whether we might learn something from them. Firstly, many countries are making the choice to use available doses to get the first shot of vaccine into as many people as possible on the grounds that most of the protection comes from the first shot. And my understanding is that there is, as yet, no evidence that the efficacy of the second shot is reduced if it is delayed. The British scientific modeling, at least, indicates that this approach will save many thousands of lives. And yet the U.S. has chosen not to pursue this approach. So my question on this first item is, if the data from the UK and also the EU, Singapore, and other countries confirms that there is a net public health benefit from giving the first shot first, should we consider adopting their approach, and when might we consider making this switch?
Yeah, so this is an excellent question. And as I said, as with many of you, I wear different hats, and I'm part of the WHO committees that's evaluated the UK vaccines and vaccines from other countries. And, you know, most vaccines do well with a longer interval. So what you're really weighing are the pros and cons of getting as many people vaccinated as quickly as you can, with the possibility that some then may never get a second dose, may have a delayed second dose and have a period of vulnerability. So some of these issues, you know, to me, the UK decisions are based on science and the US decisions are based on science. Some of these have to do with your medical care system, your culture, your understanding of the populations, and your aversion of risk. And so again,
okay, so those don't sound too scientific. You know, I'm just trying to understand. I think, but you concur that at least in terms of the modeling, getting the first shot first is a lifesaver. And then the question is, you need to talk about the sociology of your country and your culture to decide if that nets out well. But from a scientific point of view, first shot first is a winner. Is that something?
I think the UK approach is based on solid science. The further out you go with the second dose, you're getting to less solid science.
Okay. And the second choice they're making differently is that Britain and other countries are manufacturing and testing not only mRNA vaccines, but so-called self-amplifying mRNA vaccines, which can be manufactured roughly 30 times faster since they're effective in roughly a 30 times smaller dose. You know, for example, if the 1 microgram effective dose means that 1 liter of self-amplifying mRNA is enough for 1 billion doses. And so the factory is small and can be turned around rapidly. So if this plays out, self-amplifying mRNA vaccines may be the technology of choice, not only for rapid turnaround and manufacture if new virulent strains are uncovered, but also for vaccinating the 7 billion people from around the world. So my question, you know, in the U.S., we are not pursuing Operation Warp Speed style speculative investment in manufacturing self-amplifying mRNA. And is this something that we should consider?
So we should absolutely be considering second generation vaccines. The self-amplifying mRNA vaccines are being supported through NIH, not through the...
but not at the manufacturing level, right? That's the, what they're doing, Shattuck and these guys in, I think, Imperial College are actually, producing non-trivial amounts of this, even as they are being tested in clinical trials, which is something we're not doing. So that if it turns out that this is the killer technology, they'll be ahead of us, and once again we'll be dependent on on other countries. So that's anyway. Yeah. If you have a more something more complete for me to read, I'd be interested in your letting me know about that. The third thing that they're doing in England and elsewhere are human challenge trials. These are currently ongoing in the UK. As you know, all vaccines are very rapidly tested on monkeys, and they get the answer in 1 to 2 months by vaccinating them and then deliberately exposing them to the virus. And we regularly use challenge trials, human challenge trials, to test flu vaccines and other vaccines. But after a lengthy debate, we've decided not to do that for COVID-19. And instead, we're using much more lengthy, conventional field trials, which have taken 6 months or longer. And so the situation I'm worried that we're going to be in is that with a combination of self-amplifying mRNA and pre-approved human challenge trials in England and other countries, the British are going to be able to respond much faster than we will to new strains or new pandemics, perhaps in as much as 4 months, and many months faster than the US will be able to do it. And are we missing something? Are there opportunities here that we should be thinking about taking?
Yeah, so I have published on the human challenge controversy, and I come down on the side of, and I've done human challenge studies for influenza virus. I come down on the side until we have an oral antiviral that works. I feel that there's too much risk. However, we should be developing the challenge models now, preparing the challenge strains so that when we feel it's safe enough, we can quickly move into those challenge studies. And truthfully, the large clinical trials gave us the answer on vaccine efficacy before the challenge studies gave us the answer on vaccine efficacy.
Yeah, because of the approval process. If we had a pre-existing approved facilities ready to go, then you would have seen the same turnaround for human challenge trials that we currently see for primate trials. And so the question is, should, for the next pandemic, we have the approvals, the ethical considerations all set, so that we'll be in a technically limited schedule for rapidly testing those vaccines. Had we had that in place and chosen to use it, we would have known many months ahead of time that the vaccines that we are currently deploying were very effective and would have been able to ramp up production even faster than we did. So I think that, this is a debate I think that should continue even after this pandemic is ended because of its potential use in future pandemics. Well, I just want to thank you for everything you've done here. And
thank you.
Thank you very much. Next.
Mr. Garcia is next.
Hi, good afternoon, and hopefully you can hear me okay. I want to thank the chairwoman for her leadership on this, Member Lucas as well, and the witnesses here. Really appreciate everything you've done for our nation's security. It actually is an impressive feat to have gotten where we are with so many vendors so quickly. I'd like to start with just a quick nuanced comment here before I ask my question. I think to Dr. Buttenheim, your comments earlier, and I mean this in a very constructive manner, so please don't take this critically, but I think it's important when we're in an effort to try to get everyone to get vaccinated to the max extent possible, that we don't necessarily push to ask people to not ask questions. I think this is different than a normal flu vaccination. It's got much more publicity. The average American is much more aware. They're much more informed about what's going on. So I think when we say we need to try to remove cognitive load from people's decision-making process or discourage them from having choices, I understand what you're saying, but we have to be eyes wide open that when we use language like that, some demographics will actually become either more paranoid about the vaccine or less trustful of the government. We talked about the Hispanic community with the use of warp speed, trusting the process less because of just the language. So I completely understand what you're saying, and I agree with everything at an academic and science level. I think we rather than discouraging people from asking questions, we should make the answers to those questions more readily available. And in the end state, I completely agree with you. They're all great products, and you're going to be saving your life with any of these vaccinations. Just a nuance, but I think it's important, especially in public forums, which these all are, right? So my question is to Mr. Reed, I think, and we can follow up with Dr. Newswell. In California here, we're close to the bottom, 5 states in terms of distribution, and the supply chain failures getting not only dosages here, but distributed. What are the single or the I guess the 3 or 4 biggest barriers to getting the vaccine to a more widely distributed network at the CVS, the Walgreens, the Walmarts, wherever you would have normally gotten your flu shot or your birth control or your prescriptions refilled? Besides the cold storage, because if we get through that, or if there's a vaccine that is sort of amenable to wider distribution, what are the follow-on barriers, I guess, to ensuring that wider distribution?
So for us, we did not initially engage a lot of those the pharmacies and some of the smaller providers around the state that could have direct access to Oklahomans. We did that because in the initial stages, when we had limited vaccine, we were trying to move towards mass vaccination to get the vaccine out there much quicker and start to try to have an impact on interrupting the transmission of COVID. We did initially, within the first probably 3 to 4 weeks, start to send some vaccine to some federally qualified healthcare centers and some other smaller outlets, if you will, other than mass vaccination. And the challenge for them is systems in which they can run through that vaccine rapidly. So we started seeing obstacles of diluting the vaccine inventory in any one area. And in doing so, vaccine would start to sit on a shelf. So I think it's important for us to engage all these outlets. Our pharmacy partners, we're pleased with the federal pharmacy retail program that's coming on board. Right now we have 76 pharmacies in Oklahoma that are participating in that, but it's smaller doses, 100 doses here, maybe 200 there. And I think it's important for us that we give them inventory and ensure they have inventory that they can run through in a week's time, because they don't have the resources to set up large volume mass vaccination. So we want to equip them with the vaccine inventory that they can run through within a week or so that we can ensure that vaccine is continually moving from freezers into homes in a rapid manner. Now, when vaccine inventory comes up, we have more vaccine. I think we're in a much better shape to push out more vaccine to those individuals so that we do have that access to that trusted source at the local level.
This is Phil Huang. If I could add one thing to that, just, because initially that was what our plan in Texas was. Like, we have over 800 local providers signed up to be part of that distribution. And, then the state published a map with all these, and some of the pharmacies that had it. And then they were getting overrun with calls, but they only had about 100 or so doses to last a week. And that's where there was a big pivot to moving to these hubs and the mass vaccination sites. But that was sort of, given the current situation, the limited availability. I think we're trying to get towards that. I think it sounds like the federal pharmacy program is to start to get that supply going and testing it out. And once there is much more availability, then that'll be a big part of certainly our efforts also.
Great. Thank you, guys. I have a bad connection here, so I apologize, but thank you, Madam.
Thank you. Next member.
Mr. Caston is next.
Thank you, Madam Chair. And I feel I speak for all of us that I'm going to keep my fingers crossed that I don't have any Wi-Fi issues. the second line of questions. I really appreciate you all having this meeting and the thoughts you've all done in this. I feel like there's our need to communicate vaccine safety in public forums, and then there's the reality that all of us have as members. That I think every time I fly back and forth, someone on the airplane or someone at TSA says, you know, this vaccine was rolled out too quick, and I'm a little bit nervous. And we have all these little small conversations. And I don't know if I do a good job of that. I feel proud that I think I convinced a police officer at O'Hare a couple of weeks ago to go get his vaccine, but you never know how all that works. Dr. Newsel, I wonder if you could comment. I saw some analysis early on that I found compelling, but I'm not a doctor. That a part of the reason these vaccines got developed so quickly was because the community spread of COVID was so much more widespread and so much faster than we thought it was going to be. Is that accurate? And if so, can you explain for the layman how that works?
Sure, that is accurate. So as I've said, we have large numbers of people in these trials. The minimum was 30,000 up to 45,000 or more. And the way we look at a trial is we do sample size and power calculation. So when do we feel confident that the answer we are getting is the right answer? And that depends on how many cases of a disease, in this case, COVID-19, we get. So I just finished a typhoid vaccine trial. It took 3 years because that's a much rarer disease. So because we had so many people in this trial and there was so much COVID, we had hundreds of cases of COVID-19 in a short period of time that could tell us how well these vaccines worked.
How much, this is an estimate, but how much do you think that shortened the trial time from what people were, because early on, everybody was saying this is going to be 18 months. Does that substantially explain the difference?
It does. I think there are two parts that explain the difference. We ended up enrolling more people. So initially we were going to enroll 5,000 to 10,000 people, and we increased that to 30,000. And partly was so we could get these subgroups, the older adults, the minority populations, and have good numbers in every subgroup. So the size of the trials helped shorten it, and then the extent of the pandemic. Okay. So the second one, and I want to be a little bit careful on how I ask this because it's a politically charged question, and I don't mean to get political, but I don't know how you have a public health conversation and not inject some politics into it, because people, especially when it comes out of the mouths of people like us, and this builds a little bit on your exchange you had with Mr. Babin. With almost 500,000 Americans dead from COVID, I hope we never, ever again talk about how herd immunity is a good strategy to protect the population. At the same time, I think there is a reasonable question that Dr. Babin was asking you of how protected are you if you got exposed and were either non-symptomatic or had minor symptoms. And I take your point that we don't really know enough yet about COVID. But I wonder if you're comfortable, can you speculate at all on the broader classes of coronaviruses or RNA viruses more general? Can you say anything generally about the level of protection you get from a vaccine as opposed to the level of protection you get from community exposure? How durable is one versus the other? Is there a point where you're satisfied that one is going to be better? Can you say anything generically to help us answer that question when people who have been, I think, infected by a very dangerous political idea ask us what's on its face is a reasonable scientific question? Yeah, so I think there's two answers. One is just to clarify, when we talk about herd immunity, it could be through exposure to the disease. And as you've alluded to, that comes with the risk of people getting sick and dying from the disease to get that immunity. What we'd ideally like is herd immunity to come through the rapid rollout of vaccines. But in fact, it will be both of those added together that give us that herd immunity. There are certain examples where the vaccine is better than the natural infection. HPV, human papillomavirus vaccines, are actually better at protecting you longer than getting the infection. With coronavirus, I would say the jury is still out, but it appears that both in infection, reinfection is rare before about 6 months and maybe longer. We just haven't had enough experience with the virus. And similarly, about 6 months after these vaccines are given, we're still seeing relatively high levels of antibodies. So time will tell how long that immunity lasts from a disease and from a vaccine.
Thank you, and I'm out of time. Would love to talk longer, but I really appreciate it. Yield back.
Mr. Fincher's next.
Thank you. Thank you, Madam Chair. Thank you, Ranking Member Chair, also. First, I want to thank each of you, the witnesses that are testifying today. It's very important that we discuss how we can both expand access and reduce skepticism of the vaccine to get our communities back to a state of normalcy. So, Dr. Newsel, Iowa State hosts a nano vaccine institute, which received CARES Act funding to pursue a nano vaccine research and development. As you may know, this technology would allow patients to self-administer an inhaler to receive a vaccination, which is likely the preferable method, as a lot of people hate needles. For healthcare providers, it reduces exposure to contagious patients and avoids cases where providers have to be forced to throw away vaccines because there's just not the storage to preserve them. Your testimony mentioned that the need to invest and prepare for future pandemics. Can you share if this is very critical or how we can further invest into this type of nano vaccine type of treatment?
Yeah, so thank you for the question. And I stressed in my testimony both the basic science as well as the technology. I think people thought that mRNAs as a formulation for vaccines, a few decades ago just did not seem realistic. And you're alluding to delivery strategies, which is actually a top priority of the World Health Organization in terms of the next innovations for vaccines and vaccine delivery. So I can't comment on the specific of the technology that you are referring to, but I can wholly endorse, again, investments in technology, investments in vaccine delivery methods that are alternatives to injections.
Well, thank you, Doctor. And I just want to say I applaud Iowa State University and others for looking at nano vaccinations. I just think that's the way to the future when we start vaccinating. Hopefully we never have a pandemic like this again, but we always have to be very aware of our future and the research that's out there. And I think nano vaccines come to light as sort of the next way of giving vaccinations. So again, Dr. Newsel, thank you for those comments. I yield back the balance of my time. Thank you.
Representative Lamb is next.
Hey, thank you all for being here, and I'm going to proactively apologize if you hear a 2-month-old baby screaming while I'm talking to you. He's being quiet at the moment, but he's on the other side of this wall. Ms. Newsel, just wanted to ask you quickly, you emphasized the importance of the NIH research leading up to the pandemic that put us in a position to develop the vaccine so quickly. Is it fair to say, in layman's terms, that if we had not made those specific NIH investments, that it could have added years onto our vaccine development process? In other words, that the money we spent in past years probably saved us years of time getting to the vaccine?
I would say it saved us perhaps a year of time because the protein vaccines are being tested now, and that's the other technology. But I think it would be fair to say, it saved us 10 to 12 months, certainly.
Thank you. Professor Buttenheim, thank you for your work in our great Commonwealth of Pennsylvania. Wanted to ask you a little bit about the vaccine uptake so far in Pittsburgh and Philadelphia, sort of two opposite ends of our state. But the common thing that we have seen in both places, and many people have commented on this, is a higher rate of very serious infection, particularly in the African American and Hispanic communities, but a lower rate of vaccine uptake. So, for example, the numbers I have here, that in Philadelphia, only 12% of people vaccinated in the first weeks of the rollout were African American, while the city's population is 44% African American, and a much higher share were going to hospitals. In Pittsburgh, we saw the exact same thing. So what we are looking at is how to make the specific investments that will fix this problem. Obviously, beliefs related to vaccine are a big issue. But if we just kind of set that to the side, would you agree that the massive investments we're about to make in community health centers, federally qualified health centers, and the hiring of 100,000 people directly through local public health departments, do you think that those will help us make an impact on these disparities?
It's a compound question with a lot of complexity.
Yeah, I'll give you the rest of my time to answer it. I just kind of wanted to set up that in the COVID rescue package that we're about to pass,
yes,
there are billions of dollars for these things, literally hiring people and sending them to these areas of need.
Yep.
And our goal is to, start to correct this disparity in who gets the vaccine and who's at risk, most at risk for infection. Do you think that will work?
I think it will work. And I think the other ingredient that's needed when the implementation of those programs is that we are smart about what barriers different people are facing. So when you give us the statistics for Philly that say 11% of the people who've been vaccinated are Black, but our city is 40% Black, there's a lot of heterogeneity. There's a lot of variation underlying that. Some of those people don't want to be vaccinated, and the kinds of programs and outreach and support we need to get them to make a good decision for them look one way. Some of those people, never got the email because they don't have email, or have been confused by the portals, or aren't easily able to hop on a bus and get to the vaccine site. So back to my earlier testimony about making it as easy and hassle-free as possible, that's a different kind of intervention. So just like we want to accurately diagnose whether someone has COVID, we also want to accurately diagnose where people are in that journey, let's call it, to getting vaccinated, and use those incredible federal dollars that support to target and tailor interventions to help people along that journey. One specific example.
I think what I was trying to suggest is that by spending the money in this way directly to local public health departments and community health centers, we're going for a geographic distribution of manpower, or person power, rather than saying, using all the money on FEMA setting up mass vaccination sites in every city that you have to have transport to. So I just kind of wanted to get confirmation that you think that goes along with what you're calling it, making it easier, which could then help have kind of a snowball effect for people in those communities to get it.
It does. And, FEMA might work great in some jurisdictions, and the stadium might work great in others. So, figuring out what assets we have locally to leverage is really important, because it's not one solution. We know that pharmacies have worked differently in different areas.
Great. Go Quakers, and thank you for participating, everybody. Madam Chairwoman, I yield back.
Thank you.
Mr. Obernolte is next.
Well, thank you very much. And I want to thank our panelists for participating in the hearing. I think I speak for most of the members of our committee when I say that the development of human vaccines is probably one of the crowning scientific achievements of our human civilization. And that in the science of vaccination, that development of the coronavirus vaccines is probably going to rank as one of the crowning achievements in that field of science. So, having said that, I think it's really important for us to take a retrospective look at the development of the vaccine and our efforts to deploy it, so that in the future, the people that sit in our seats and make these decisions will have good information to rely on, so that we can do it even better next time. And so I think that that's the line of questioning I'd like to pursue. First of all, I have a question for Dr. Huang. I think many of us were encouraged by Pfizer's announcement yesterday that
its vaccine might be stable at higher temperatures. Can you tell us what implications that has for our efforts in getting the vaccine distributed quickly?
Certainly the requirements for the ultra cold freezers is a challenge. It's one of the logistic challenges for getting it out there. It is surmountable, but it would certainly make it easier for delivery. Thus far, our local health department has been primarily dealing with Moderna, but we have partners that we're working with for that ultra cold storage. So I would think certainly in rural settings and other settings, certainly would simplify the ability to get vaccine out. And as Dr. Buttenheim mentioned, just making it simpler, addressing these sort of things, barriers that we can, that would be one of them.
Thank you very much. And Dr. Newsel, I had a question for you. It's very interesting that our states have kind of served as the laboratory of democracy during this epidemic, because many different states took different approaches to economic shutdowns and efforts to reduce the spread and transmission of the virus. And it's kind of a scientist's dream, right? Because we have lots of different settings that we could look at statistical evidence and figure out what worked and what didn't. And I think a growing body of research is indicating that the virus followed similar trajectories in states with very different approaches to shutting down their economies. So can you tell us your view of what that means for future epidemics? Because we know that this is going to happen again. This won't be the last time. In the future, should we have pursued the policy that we did regarding economic shutdowns?
Yeah, so thank you for the question. It's a complicated question, and my conclusion might be a little different than yours. I think that there are so many variables. We scientists like controlled experiments. So if I'm going to do a controlled experiment, I want everything to be the same except for one variable. This group wears masks and this group doesn't. And as we know, a lot of the behaviors and actions that were taken tracked together. There is, in fact, evidence, and the CDC has provided evidence that many of these mitigation measures did work. Certainly the masking, now the double masking, the social distancing, and the limiting large crowds has been shown to work. Again, it is hard to dissect what single variable might be contributing there. So I think it's going to take a scientific approach, and we should have that scientific approach to how these differences, what's worked best, where did it work, et cetera.
Okay, thank you. Yeah, I was talking less about masks and social distancing, where the science is more clear, as you say, and more about shutting down, for example, indoor dining, forcing employers to do remote only instead of having controlled office environments, where we've got states that took very different approaches, like Florida and California, that seems to have similar trajectories of the spread of the virus and recovery from the epidemic. And last question for Dr. Buttenheim. I was fascinated by your testimony on vaccine hesitancy and distrust of government. And I completely agree with you that this is less a discussion about virology and more of a discussion about psychology when we're talking about overcoming vaccine hesitancy. However, I think that something Dr. Huang said about distrust of government really resonated also, which is that people don't want to feel like their government is forcing them to get the vaccine. And I think we have to be very cautious about that, because in a way we've said we're not going to make it mandatory, but in other ways we're kind of telling them that they are. If we're telling them that their children have to be vaccinated to return to school, if we're telling them that they have to be vaccinated to get on a commercial aircraft, what are your thoughts? How do we tread this path towards steering people in the right direction to get vaccines, but not alarming them by requiring them to get it and enhancing this distrust of government?
Yeah, this is a question we're getting a lot. Sort of, where do mandates potentially fit in with this vaccine? And most of my research pre-COVID was on the childhood schedule and whether you have to vaccinate your kid to go to school, to have the kid go to school. So very, very relevant. Fortunately, just regulatorily, we're still in emergency use authorization, and we don't actually have to contemplate mandates quite yet. We're very unlikely to mandate a vaccine that's under an EUA. But it's gonna be a fine line. I really think about this as not trying to get to 100% or 80% of people vaccinating, but trying to make sure that everyone's been reached with information and support to make the decision that's best for them. That's really different from how I think about sort of parents vaccinating their kids. I want you to get your kid the measles shot, sort of, the end of story. But we are obviously going to have situations. We mandate flu vaccine for healthcare workers in some settings in some states. There are going to be airlines that are going to say, just as you have to have your yellow fever vaccination to travel to certain areas, you have to have your COVID vaccination. What schools and colleges do about students coming back, especially I think it's going to be more relevant for colleges with congregate living, maybe than for elementary schools. But those, luckily we have sort of templates for those conversations. But for the general public right now, there should not be even the feeling of mandate or must. Maybe there can be some language around should or would be great, or we're very gung-ho about this and we hope you are too. But we can absolutely steer clear of mandate language for now.
Okay, well, thank you. Well, I see my time's expired, but thank you for that testimony. I completely agree with you. If I know my constituents pretty well, if they get the idea that they're being mandated to do this by the government, it's just going to enhance distrust and it's going to make vaccine hesitancy worse, which is the wrong direction to go.
100%.
So thank you very much. And Madam Chair, I yield back.
Ms. Stevens is next.
Unmute.
Can you hear me?
Yes.
Great. Fabulous. Thank you, Madam Chair, for this phenomenal hearing. Couldn't imagine a better way to kick off the Science Committee of the 117th Congress, and thank you to our expert witnesses. I'm talking to all of you from snowy Michigan, where the president is today. He's in Portage, Michigan, visiting Pfizer, the place where the first vaccine rolled out to our great expectation. Dr. Nuzzle, I want to thank you so much for your testimony, which was really thorough and historic in nature. And certainly today we've spoken a lot about the efficacy of the vaccine, and I know that's a topic on everyone's mind, from my constituents in Michigan's 11th district who are working to get access to that vaccine. But I just love to talk to you a little bit more about the vaccine development, of which Dr. Baird also touched on with his very specific questions around the mRNA. But more so to just back up for a minute, because one of the things that we focus on in this committee are the scientific achievements. We focus on the milestones. Many of us recall, and I say many because we've got some newbies in Congress on this committee this time, freshmen, but those of us who were in the 116th Congress recall that the first thing that we voted on, and it was all of Congress, completely bipartisan, immediately signed into law, done at the beginning of March, was the original money to go into the development of this vaccine, to go into the R&D of the vaccine. And here we have it, where we got it within the year. You touched on Operation Warp Speed. But for somebody who is in this space, have you taken any moments to just pause? And if you have, what has been the thought? Is this something that surprised you? Was this expected? Did you think we were going to be able to get this done before the end of the year?
Yeah, that's a great question. And I've been involved in a lot of vaccine development, very large public-private partnerships in my career. And as you've said, this one is absolutely historic. I think last year at this time that we were all saying, best case scenario, we might have a vaccine by the end of the year. When you say stop and reflect on December 31st, I got my vaccine, and that was really a very powerful moment for me personally, that within the same calendar year, I actually received a vaccine when I was there at the beginning for development. So I think certainly without the resources, but without the vision, without the leadership of bringing a diverse community together, bringing partners together with different skill sets, united to a common goal, was absolutely key to this happening.
Right. And one of the privileges of being on the science committee last term, and it's worth reflecting on, we, in March, voted for the funding for the vaccine, voted for a second package around increasing our SNAP benefits for food assistance, paid family leave provisions, and more money for the testing. And then we voted for the CARES Act. And being on the science committee, we got additional dollars out to our manufacturing extension partnership network. Yay. And we also got money over to the National Institute for Innovation in Manufacturing Biopharmaceuticals, known as NIMBLE. And this is part of the Manufacturing USA network. And again, we've talked a lot today about the distribution. This has come up in previous questions around where the supply is, how long the supply can last. But I just remember that conversation with Mr. Keldon Lee, their director, and asking him about the ability to distribute this vaccine, given what we were seeing in the early phases. We remember about 13 months ago, testing wasn't available. And so I don't know if you all want to rate, in terms of how this vaccine has gotten distributed, but if there's anything else that you'd want to reflect on in terms of getting the shots in the arms of I'd say with my residents, but the American public, and in particular, what we're seeing with those who have adopted the models of working and coordinating with the pharmacies directly, those states versus those who haven't. And this is just if anyone has anything left to add. I know Madam Chair, I'm right at my time, so we might have to do it for the record, which would be fine. So I'll yield back.
Ms. Kim, next.
Thank you. Thank you, Madam Chair and Ranking Member Lucas. I want to thank you for holding this very important hearing on the science of COVID-19 vaccines. I don't know if all of you are having technical difficulty like I have. I've been in and out sometimes because of that. But I also want to thank our very patient and expert panelists for joining us and answering our questions. And I look forward to working with the members of the committee on both sides of the aisle to ensure that U.S. stays at the forefront of science, research, and development and innovation. This is really exciting for me as a freshman to be able to serve on this committee because, as COVID-19 is affecting communities in different ways, and this so-called K-shaped recovery has allowed families and individuals with higher incomes to weather the economic crisis much better than the low-income and minority families. Unfortunately, the COVID-19 pandemic has also had the biggest negative impact among minority students and low-income students. There was a study of San Francisco found that minority and low-income students have suffered the most as school districts have stayed with virtual learning. And the January 25th study by PACE, which is an independent, nonpartisan research center based in California, found in a study of 18 California school districts that, quote, certain students, especially low-income students and English language learners, are falling behind more compared than others, end quote. Clearly, this study is problematic because many of the students are falling way behind on math and reading skills, which are obviously critical skills if our country wants to have successful STEM students. So moving forward, we need to ensure that we have a seamless vaccine distribution so that we can get to that point where anyone who wishes to get a vaccine can have access to it. We must also ensure that our research and development of vaccines are keeping pace with the variants that have been recently found. So I'd like to pose a question to first Mr. Reed. Talking to my students in California's 39th district, it seems in the individuals often do not know which entity in the state is administering the vaccine distribution. And there is a lack of communication between the state and local governments. And in your testimony, you discuss how partnership with regional health directors, county health departments, and other local partners are critical in determining the best communications approach for local constituencies as they understand what would work well within their respective communities. So could you elaborate further on these partnerships and provide examples of how different constituencies communicate with their residents?
Certainly, and I was having a little trouble hearing you, so hopefully I heard the question. Yes, our local partnerships have absolutely been key in our vaccination rollout. We've been very clear having a centralized planning, but we depend completely on a decentralized execution of that plan. I'll give you an example. We are rolling out to teachers starting next week, and from the state level, we have just identified that that's part of the next group that is coming online for vaccinations. And then we allocate vaccine to our health districts around the state. We leave it to them to work with partners on to develop those plans. In some cases, they are setting up specific pods that are for school districts and their teachers. In some cases, they are using strike teams that will go to some of these districts in order to vaccinate the teachers. In some cases, they are pulling multiple districts together to come together for one pod. Some areas, they are using contractors that can go out and use strike teams. We've essentially left it up to them locally to determine what they can do best because they understand those resources. They understand the needs of their partners. They're in constant communication with those partners, and that's really why it helps them to understand how best to move forward with vaccination efforts. I hope that answered your question.
I'm pretty sure you did. My apologies. As soon as I posed that question, my computer froze, and so I had to log back in. I'm sorry we're having this problem. But thank you for answering that, and I do have a follow-up question if I still have some time. Madam Chair, how much time do I have?
Time has expired.
Thank you. I know that.
Mr. Sherman is next.
Thank you. I want to thank my colleagues who focused on distribution and acceptance and getting disadvantaged communities, communities of color, rural communities, of the acceptance and the vaccine they need. There's one other group that has a very low level of acceptance of a vaccine, and that is Trump voters. And I'm hoping that some of the members of this committee who have a better personal relationship with the former president than I do can prevail upon him to go public with his support of these vaccines, and that when members of the Trump family get their vaccination, when it wants to be vaccinated or thinks he shouldn't be because he's already had the disease, if he were present where other members of the Trump family were getting the vaccine, that would go a long way. I want to focus on the shortage of vaccine. Now, one concern I have, and this is the only thing I disagree with Dr. Fauci on, is he's been on the shows talking about how certain steps we could take that would conserve vaccine, study how we could conserve vaccine. Really wing, because by the time we get the results, most Americans, all Americans, will have access to the vaccine. It's not enough to vaccinate just the United States. We've got to vaccinate the world. That's a matter of more our world leadership. It's a moral issue. It's an international economics issue. But also, as Dr. Nutzel pointed out, it relates to our health. Every time anyone in the world gets this disease, it gives the vaccine enough, it gives the virus a chance to replicate, mutate, and perhaps come back to the United States in a form that we can't deal with. So we do have an interest in the entire world being vaccinated as quickly as possible. It means not stopping our efforts to maximize the efficiency and protection of the vaccine just when we all get vaccinated in the United States. But one issue here, while we do want to vaccinate the whole world, we're most interested in vaccinating the United States, is that there's vaccine being manufactured in the United States, which is being exported. And we have the Trump administration didn't, and so Pfizer and others signed contracts with the country. We could legally interrupt that with the Defense Production Act. Or a contract's a contract, and we want to maintain our relationship with our friends. Speak up if you know to any degree how much vaccine being manufactured in the United States is being exported in the first 3 or 4 months this year. Do any of our witnesses know? I'm going to go on to another question. We can research to determine whether one Pfizer drop now and one in the late summer is enough, whether 1/2 or 1/3 of the current dosages are fully effective for people under 5. Those studies are going on now. They should have started 18 months ago. But I want to focus on the issue of actually have the model you're putting it in. It's FDA was instructing medical professionals to take out of the Pfizer and throw the bottle away after that. They finally went and say you can get the 6 dosages. God knows how much vaccine was wasted. Even now, I'm told that there's a 1/2 dose available in this bottle, and then you get the next 1/2 dose available in this bottle, and from the same manufacturing lot. You're supposed to the vaccine in that first bottle. It doesn't in that bottle for a full dosage, you throw it away. Is that does any of any witnesses have that ground experience or medical professionals for real a 1/3 of those, 2/3 of those
Mr. Sherman, much of your audio was cutting in and out, so I think the witnesses weren't quite able to hear the questions exactly.
I'm going to turn off my video and hope my audio will improve. Is my audio better now?
It does sound a little better, sir, yes.
Okay, I don't know if I have the time to restate the question, but I'll ask any of our witnesses, are you familiar with the process by which if there's maybe 1/3 or 2/3 of a dose left in a bottle after that you throw that bottle away rather than using some of the serum in this bottle and some of the serum in the next bottle, that next bottle being with the same manufacturing lot in order to administer a full dose? Are we throwing away 1/3 or 2/3 of a dose every time we finish a bottle?
This is Phil Huang. I mean, I would say that, we have certainly been very diligent in getting as much out of each vial as we can and have been getting more than what was on the public. But in terms, yeah.
What you can get out of the bottle is 1/2 a dose. You can get 1/2 a dose out. You can't get a full dose out of the bottle. The tray is from the same manufacturing line. Do you throw away that 1/2 dose in the bottle that has already been mostly used?
I haven't specifically heard regarding that availability. We have tried to get different syringes that make it easier to maximize the amount. But
we've got the better syringes. We've stopped wasting whole dosages, but we are still wasting on average 1/2 a dose per bottle. So that would mean 1/12 of the serum is being thrown away. And that's thank you, FDA. I think they'll correct that months from now. And I yield back.
Mr. Weber is next.
Thank you, sir. And Madam Chair, thank you for having this great hearing. And you too, Mr. Ranking Member, we appreciate it. Gosh, I don't know where to start. Let me do it this way. I think Dr. or Allison Buttenheim, in your exchange with Dr. Barra, you said the best vaccine is the one you can get tomorrow. And so people are concerned about we've got two different kinds of vaccines, right? We have Moderna and Pfizer. How close are we on Johnson & Johnson? Do you know?
I think their EUA hearing is next week. But we also know that there will not be the amount of supply for that vaccine that we have for Pfizer and Moderna. So it's not like we'll suddenly have another third of supply. There will be limited. Right. We've been told in Philly we will have much more limited supply of J&J.
And this may be a question for you and Dr. Newsel, I guess it is. That do we have a comparative analysis? In other words, how successful is the Pfizer? How successful is the Moderna? What are the numbers there that have been vaccinated? What are the numbers of adverse reactions? Do we have that kind of information?
I shouldn't speak to post-marketing surveillance. It's not my area of expertise, and unfortunately, I think Dr. Nozell had to drop off. But in general, the trials continue, and that we still, through our different monitoring and surveillance systems, the local folks here who are vaccinating locally can attest to this, gather all sorts of adverse event data, and we're starting to accumulate the longer-term safety and efficacy data. That's ongoing and will be for months.
Okay, in her exchange with Mr. Tonko, I think she said herd immunity was around 75 to 80%. Do we know where? I guess that's the ideal herd immunity, quote unquote. So where are we now? Do we know that?
Well, we know the number of doses that have been delivered, and we know the number of people who've had 1 dose versus 2 doses. The mystery number is how many people have actually had COVID and how much do they contribute to herd immunity, meaning how long are they protected? I've seen ranges from about 20 to 40%, it's a big range, of residents in the US have some form of protection now, either through prior disease or through vaccination.
Okay, and you talked about the need for local jurisdictions to be able, pardon me, to track that progress.
Yes.
Are we finding different jurisdictions, Texas or others, do things better and are tracking this better? Is there a model jurisdiction out there that you would recommend?
I should let Dr. Huang and Mr. Reed weigh in on what they're doing. North Carolina has a great dashboard. Many states have dashboards that are not being run by the government. They're stood up by talented citizens who want to be able to see this. But I think, again, we need to sort of rapidly share best practices and how to collect and analyze and display that information to guide decisions.
Well, thank you for that. And I do want to hear Dr. Reed and Dr. Wayne. Dr. Reed, what say you?
So one thing I would say is that we're missing a key piece of information when we start to look at our vaccination rates in our different counties and try to put that out there so that we have an idea of the rates plus the amount of disease out there. Our federal allocation that comes into the state, we don't have any visibility on what that data shows us. So that's been a source of frustration. We have a significant tribal population in Oklahoma. We have our Veterans Administration Centers. So federal allocation comes into the state, but it doesn't go into our immunization registry, so it's a blind spot for us. We don't know what those vaccination rates are contributing to in some of our counties. So while we are putting out information about how we're doing at a county level, and now we're looking at adding on to zip code level to put that information, we really need additional data from the federal allocation so we can better understand vaccination rates within our state, because that data will help drive our decisions on future allocations and future efforts.
Well, thank you, Dr. Wang. I've got about 20 seconds.
Sure. And we've actually been working with a local group, Parkland Center for Clinical Innovation, have been processing both our testing positivity results as well as our vaccination. And so they've been doing some projections based on the number of confirmed and probable cases, but then also projections of how many other cases geographically might be out there. And we've looked at it by zip code and also by census tract. Some of the zip codes and census tracts may be about 30% perhaps protection, and even up to 60% in some of the areas, but there's still preliminary data that we've been looking at.
Okay, thank you. I appreciate that, Madam Chair. I yield back. Thank you.
Thank you.
Ms. Ross is next.
Great. Can you hear me? Great. Thank you. Well, perfect timing, Dr. Buttenheim, because I'm from North Carolina. I don't know if you saw me kind of doing my little happy dance about our dashboard. And I just this week had a roundtable with community health providers, with our HHS, with NIH, and with our all of the local hospitals here. And I'd like you to tell the folks why our dashboard is good and would be a model. We didn't have a fast start. We had some difficulties, but I believe we're catching up. And if you could talk a little bit about the dashboard, and then I have a couple of other questions that came out of that roundtable.
Sure. And I should clarify, the dashboard I had in mind when I said that is one of these that was set up by an academic team, Dr. Paul Delamater at UNC. And I actually don't know how well it complements the state dashboard. But what's important to see for me is, for example, in Philadelphia, it is less helpful for me to just see how many doses have been given to different sociodemographic groups. I want to see rates. So, we talked earlier about, 11% of the doses in Philadelphia have gone to African Americans, but 40% of the population is African American. Show me that in rates, so I can very quickly see only 3%, of this group versus 15% of that group. And then the granularity is really important, especially for jurisdictions that are going to be using something like the Social Vulnerability Index that was mentioned earlier to do equity-based allocation. You need to see that at a pretty fine level of detail. Zip code's okay, census tract actually better. So right now, for example, that you can sometimes see maps that show sort of zip code of doses given, but by provider, not by patient. So, we need to use those data. And then it needs to be dynamic. Lots of us are checking these dashboards every night, and, numbers that are really bumpy because we don't report over the weekend, or, 3 to 7 day lags are hard. So real-time data, granular data, and data that are presented as rates so that we can do comparisons are what's most useful.
And this is Phil Huang. Could I add one thing in there? Just, it really highlights the need for investment in our data systems. It came out during our testing data and all of that, but then also, as we've been going out with the vaccinations, the mass vaccination centers, getting the reporting into our state MTRAC systems, we were during the first weeks having to do it all paper-based, and so it really limited the timeliness, the amount of data we could get back. Now we've transitioned to a paperless system using QR codes, but all of these, it shows how much there's been neglect of some of these basic data systems and infrastructure for public health that really are so key.
Thank you so much. One final question. In that same roundtable, we heard, and somewhat sadly, that there was vaccine hesitancy among healthcare workers for them to get the vaccine. And that's concerning, obviously, because they are in contact with patients, but it's also concerning because they're supposed to be our ambassadors to good healthcare. Could you tell us what you've been learning about convincing all of our healthcare workers to get the vaccine?
So, this was a really important area of focus because that was the first group that we vaccinated. So we had data quickly on sort of which groups were saying yes and were saying no. I will say the same race ethnicity-based disparities that we see in the general population, we got a signal about that in healthcare workers, also by occupational group, which is of course correlated in many cases with race ethnic groups as well. And one area where we're particularly seeing gaps is in the long-term care or nursing home workforce. So I think there's nothing sort of different about how we're going to approach this. Some of this, again, is going to be these longer term, more intensive face-to-face conversations, making sure people have repeated opportunities. It wasn't just like there was this one chance to get vaccinated and you missed it. And figuring out who are the sort of persuasive peers or the validators that can help bring people along.
And are there any incentives to getting vaccinated? How does that work? And I know that there have been some folks in North Carolina who have looked at that as well.
It's hard to do justice to in 20 seconds. Incentives are very controversial. Does a $20 gift card work? Does a $1,500 big investment that looks like relief money work? My personal opinion as a researcher is that this is not a great place to use incentives. And one reason I'll say about that is that one thing incentives can do is signal to someone that the behavior you're incentivizing is difficult or risky or hard or unpleasant for some reason. And I think that's not the message we want to give with this vaccine. But I know there are lots of interesting programs and experiments with trying incentives.
Thank you. And I yield back.
Representative Moore is next.
Thank you so much, Madam Chair, Mr. Ranking Member. I have really enjoyed listening to this panel of experts, and I have more questions than I do time. So let me just get right to it. Madam Chair, I want to enter a couple of things into the record without objection. I would like to enter a Pew Center research report recommending, quite frankly, that pregnant women receive the COVID vaccine. The American College of Obstetricians and Gynecologists. I'm sorry. The American College of Obstetricians and Gynecologists has observed that pregnant women are more vulnerable to severe illness and death, and they recommend that they get the virus. And then I also want to put in the record a study from the Pew Research Foundation that talks about the age gap between whites and other minorities. Without objection, Madam Chair.
So ordered.
Thank you, Madam Chair. I put those things in the record to tee up questions, and I'm not sure who is best to answer, but I'll start with Dr. Zaidima. When we talk about vaccine hesitancy, let me flip the script a little bit and say maybe some of the hesitancy has got to do with some of our organizations, the World Health Organization, the CDC. They have not been very clear about it. So if you're pregnant, you may be hesitant to take the vaccine. You might not even be eligible based on states' priorities. I was wondering if you could comment on that briefly.
And Representative Moore, to whom are you directing that question?
Dr. Newsel. I'm sorry, Dr. Newsel.
She unfortunately had a hard stop at 2 p.m. So we are without.
Okay, well, I don't care. Dr. Buttenheim, I'll take you.
Not my area of expertise. I'm going to pitch it to a medical doctor.
All right.
We can submit your question.
I'm sorry, Dr. Huang. Anybody? I'm running out of time.
Yeah, I guess what I was hearing, some that the mixed messages or the lack of clear messages perhaps causing some of that hesitancy. I think that goes back to the point we do want to, address the facts, share them in an honest way, build that trust. Sometimes things aren't always clear, but then there are the recommendations that are resulting from that. And I think that, making that clear and building that trust is part of building that, addressing the vaccine hesitancy. But
thank you, Dr. Huang. Because the reality is that vaccines have been administered to pregnant women in the past, and there haven't been any bad outcomes that we know. The second thing I put in the record was I just want to point out that while we talk about all of the hesitancy among Blacks and other minority groups, and I know we have our witness here from the Native American tribe, I just want to point out that the most common age among white people is 58. And that's double what the common age is for Black people, which is 27. And if you're just going to line up Hispanics and pick out a random Hispanic person, they're much more likely to be age 11. If you put that in more scientific terms, like the median age of white people in the United States is about 44. It's about 34 for African Americans, 10 years difference, and then 30 for Hispanics. So, so if a state rolls out a plan to vaccinate all the 65-year-olds first, that's fine. Then we're going to move down to the 55-year-olds. You could be inadvertently, I would say, agreeing to vaccinate white people first. White people were the baby boomers. I'm 69, but literally, my son, who got off the respirator on December 31st at his age 43, is wondering, is it ever going to be his turn? So I just want to comment on that in my 7 seconds.
I would say for us,
go on.
Oh, I would just say for us in Oklahoma, the only age disparity that we created was we cut off 65 plus, and that was based off of the morbidity data that we had in Oklahoma. And then at this point, we're moving to any adult under 65 with comorbidities. And we want to make sure that we are reaching out to our underserved communities, our communities of color, and work with our partners to make sure that we are reaching out to these communities and ensuring that we do get a level of vaccine equity that may not be based off of just the broad statewide plan. Again, we want to push that locally where we know that our local partners recognize the needs in their communities and they can reach out to those individuals and help us to reach that level of equity we need to reach.
And Madam Chair, my time has expired. Thank you for your indulgence, and I yield back.
Thank you.
Is Mr. Kildee available?
Yes, I am.
Okay, you're next, sir.
Okay, I got to start my video. There we go. All right. Well, first of all, thank you to Chair Johnson for holding this meeting. I'm so happy to be a member of this committee, and this hearing, my first hearing as a member of the committee, completely affirms what I had hoped for, that we would have a meaningful and really fact-based conversation about this really important subject. So thank you, Chairwoman Johnson, for your leadership and holding this hearing. I have been in and out of the hearing. I just had to jump off for a minute to wish my 15-year-old nephew in Ireland a happy birthday on Zoom. So I may have missed a bit. And some of this may be redundant, but the subject is so critical. I apologize for any redundancy here. Two of the communities that I represent are Flint and Saginaw, Michigan, both majority-minority communities. And as we know, African Americans are at significantly greater risk. I have lost several friends, 4 very close friends that were lifetime friends to COVID. And so this is obviously not just a big issue for us as a country, but it's very personal for many of us. For the people in my hometown of Flint, as you might expect, this trauma comes in addition to the ongoing trauma of the water crisis that many are still recovering from. And at the core of that crisis was a complete breach of trust between government and the people of the community. The lack of trust between the people of Flint and public institutions is even worse than it is in many other communities. And so many of you mentioned in your testimony the skepticism, natural skepticism of the communities of color for any institution, but particularly the medical system, because of the legacy of exploitive research. So this is not going to be easy to overcome. And I wonder, maybe starting with Dr. Buttenheim, if you could comment, as if you're speaking to the people of Flint and Saginaw, what can you tell us? What can you tell them? What, especially for leaders in the community, what are the evidence-based actions that leaders should be taking to encourage vaccine uptake and to address the distrust in communities of color? I know you've addressed this, but if you could just reiterate that for the people I represent, it would be really helpful.
Sure. And the thing I put at the top of the list is to listen. You actually don't have to do all the talking and all the information conveying up front. A lot of this is, tell me what's going on. Tell me where you are with this. Tell me about past experiences that have made, have given you concerns about this vaccine. What questions do you need answered? I do think listening can go a long way here. And then the other piece, which will not be a surprise to you with Flint, is of course to find those trusted sources. Who will people listen to? And if those people can share their why, what's your why? If they can talk about their decision to get the vaccine in sort of dialogue with people, that can go a long way too. Finally, to the extent local and state health authorities can be transparent about the conversation and acknowledge, I think if you just kind of skip over the fact that we maybe don't have trust in public health authorities, like you're already just behind the 8 ball. I don't know if that's the right metaphor. I'm not a sports person, but incorporating the recognition and acknowledgement of those of the history and the present of structural racism and institutional racism, and making that part of this conversation can also be helpful.
I wonder if you could also, Dr. Buttenheim, zero in a bit. I was really interested in your testimony. I thought it was well presented, the 5 points. But the third point you made about keep doing the hard stuff, I mean, this sort of falls into the category of hard stuff. If you could talk about how this relates to that point, that would be helpful.
Sure. And I will say, this is, science happening in real time. My guidance on this and my instinct is really coming from following some, I will say, mostly Black female physicians on social media, and some I know here at Penn, who are doing this work on top of everything else they're doing, by having conversations every day with patients, with people they run into in their daily lives. I'm thinking of Dr. Kimberly Manning at Grady Hospital in Atlanta. I'm thinking of Dr. Gina South here at Penn Medicine. And in their, literally in their tweet threads about this, they provide templates for how to have these conversations. And the first thing you realize is, wow, these women are very powerful and very effective at listening and reflecting and sharing their own stories. And boy, this work is hard. And again, you couldn't turn this into something that, you could suddenly reach 1,000 people with, because it is these one-on-one conversations. So that's sort of where that point number 3 came from in my testimony, as recognizing the power of that, and also the limitations in that it's hard to scale and it's hard to keep asking of some of these people to keep doing this labor.
Great. Thank you all. I really appreciate the testimony. I appreciate, again, as I said, the chairwoman for holding this hearing. I wish I had an hour to ask questions because we have so many, but this has really been helpful. Thank you. I yield back.
Ms. Wild is next.
Thank you so much. I really appreciate it. I would like to join in Mr. Kilde's comments regarding this committee. I am new to the committee. I am thrilled to be on it, and I think that the very substantive nature of this hearing is exactly what I was looking for in terms of a committee. So thank you very much, Chairwoman. My questions, I'm rather late in the questioning order. My question was going to be for Dr. Newsel, but I'm going to ask Dr. Buttenheim if she might be able to assist me with this question. In recent weeks, we have seen news of viral variants reaching U.S. shores. Evidence suggests that some of these variants may be more contagious than the original SARS-CoV-2 virus. And I've seen a number of anecdotal stories about some severe concerns with how quickly one of the variants in particular is spreading. Can you tell us a bit about how we should expect the existing vaccines to perform against the new variants? And what, if anything, do we know about the vaccines that are in the pipeline in terms of their effectiveness against the new variants?
Thank you, Representative Wild. I wish Dr. Newsel were here, because that is well out of my area of expertise, neither a virologist nor an epidemiologist or immunologist. So I will.
About that. I don't know whether any of the other witnesses have any response on that. If not, I'll move on. But if you do, please feel free to comment, Dr. Huang or.
That really would be a Dr. Newsel question for expertise.
That's fine. So let me move to a different question then. and I'll address this to anybody who might be able to answer it. A number of people have the sense that these vaccine processes have been rushed and that maybe safety took a back seat. Can you comment on the integrity in the vaccine trial data? And, you know, a follow-up to that would be that some people are queasy about the name Operation Warp Speed. I'm actually at a vaccination clinic today. I'm doing this from a hospital conference room where they just celebrated giving their 100,000th vaccination today. So that's obviously commendable, but there's still so many more people that we know are going to need to be vaccinated. Is there any indication that scientific integrity and the safety of patients ever took a back seat in the federal government's effort to support the vaccine development? Anybody want to field one?
Again, I would say that probably Dr. Nuzzel's earlier addressed that. You know, I mean, I think that there's been, I mean, I think she covered a lot of that pretty quickly regarding the interpretation of Operation Warp Speed. You know, I did express in my testimony, we have heard that from the front, you know, people in the community, that just that term, because of the fear or the concern that it was rushed, that term does seem to reinforce that in some circles. And I have heard specifically that, and that is one of the vaccine hesitancy sort of concerns out there.
And I'm hearing that a lot too. Any best practices in terms of that you can share with us in terms of convincing people who are more reluctant than others?
Where I've seen communications be persuasive, there are sort of two aspects. One is showing how parts of this vaccine have been worked on for a long time, right? Like we actually have decades of research that got us to this point, which is why we have a 1-year vaccine instead of a 4-year or a 10-year vaccine. And I think the other persuasive piece is the confidence from experts like Dr. Nuzzel that the approval process was not compromised in any way. You know, the FDA and the CDC have traditionally been two institutions that the Americans have like a lot of trust in, that, you know, has had a rocky road the last couple of years. But, you know, experts saying, yes, all the right, you know, I's were dotted and T's were crossed that got us to these emergency use authorizations, and sort of saying that over and over again also seems to be persuasive.
Thank you so much, Madam Chairwoman. I yield back.
Thank you.
No additional members for questions, Ms. Johnson.
Well, thank you very much. And let me thank our witnesses. I do have one more question before we close out. I apologize for it taking us so long to get through it, but it lets you know how interested we are in these questions. And I know that some of these questions that I might have here might be more appropriate for Dr. Nuzzel. If that is the case, we will send the questions to her. But what are the side effects of the Pfizer and the Moderna vaccines? Are they mild or severe? And how often do people experience the side effects?
I mean, there are certainly some localized side effects, localized pain, redness, some of the common aches and pains, joint pain, body aches, headache, sometimes fever. They've typically short-lived. Some of the severe side effects, you know, I mean, that we would be worried about would be the severe allergic reaction, anaphylaxis. The only real contraindication, you know, is to have a history of anaphylaxis to any of the actual components in the vaccine, or also then, you know, there's a delay recommended just if you've had another vaccine in 14 days. But again, there are, you know, and there's protocols in place for monitoring these vaccines. There's the vSafe program where everyone's being, you know, if they sign up, get daily text messages to report these side effects.
Is it possible for a vaccine to mutate into an active form of the virus or infect someone who is healthy?
Again, it was addressed by Dr. Nuzzo. It's not an actual live virus. These are, so it can't mutate into another virus that would infect persons. Right.
Thank you. What's going on with chemicals in vaccines in general, and do we need to be worried about them?
Yeah, I don't know that. Maybe that might be something to talk to Dr. Nuzzo about.
Okay. We will submit some questions to her. One last question. Is it possible for a vaccine to cause autism?
The great preponderance of data, and there's a lot of it and a lot of studies, you know, it's hard to prove a negative, but there has not been any credible research, sustained, replicated, that gives any suggestion that there's a relationship between vaccines and autism.
And the original research was actually disproved.
Exactly.
And the author has been discredited and it's been retracted, and so.
It's an incredibly sticky worry. It's very hard to unstick people from that worry, I will say behaviorally, but no science to support it.
Thank you very much. Does anyone else want to ask any question before we close out? Well, thanks to all of you. This has been incredibly important, and I so apologize for the technology glitches at the beginning. We will try to make sure that we can try to clear those up. This is a technology committee, and I'm the first to admit that I'm a little old for the era. And so I'm just as guilty as anyone else for not knowing exactly how to clear it up when it happens. But before I close, I want to really thank all of you who testified and all of what you're doing, and to say that this committee certainly had interest in your coming today, as you can tell. We're sorry it went so long, but the record will remain open for 2 weeks for any additional statements from members or our witnesses, or any additional questions. So before I excuse the witnesses, let me say one more time how much we appreciate you being here and how helpful your information has been. Our witness is now excused and our hearing is adjourned. Thanks to all of you.